Health. So, look, welcome to this joint Health Scrutiny Committee meeting, 18th of December 2023. Really good to see you all. I know we've got a couple of councillors who are still on their way. Apparently there's a bit of a road issue on the M1, so a couple of people have been held up. So hopefully those people will be able to join us as and when they're out of the traffic. Otherwise, we will plough on with the agenda. We have got a pretty full, intense agenda today. So my plea to everyone, both those sitting around this table, but also any of our guests joining us to help with answers and debate, is to be as punchy as possible, as brief as possible, to the point as possible, and then hopefully we can have maximum amount of time discussing any of the points and get through the agenda as close to our usual target of 2 hours as possible. But I appreciate it's quite a full agenda today. So as you know, this meeting is being broadcast live to the public via the YouTube channel and will be available for viewing on YouTube after the meeting. As always, these microphones operate on a basis that the sort of cameras seek the live microphones open. So when you are speaking, please make sure the button's pressed so that you've got the illuminated sign that you know that the camera's on you and the microphone's live. And likewise, as soon as you stop speaking, if you can press the button again, it releases the microphone system and the camera system, and hopefully that way anyone who's following the meeting on YouTube will get the full benefit of sound and vision. So, also like to welcome Louise Richardson, who I can see has just arrived, who's actually the County Council Cabinet Lead for Health. So good afternoon, Louise. And likewise, as we go through the meeting, I'll be welcoming any colleagues from the health sector as and when they join us for each of the items. So I'm going to start off with item number 1 on our agenda, which is the minutes of the previous meeting. I propose that the minutes of the meeting held on the 18th September 2023 are taken as read, confirmed and signed. Is everyone happy? Okay, excellent. Thank you very much. Item number 2, question time. No questions from the public were received before the deadline. I did, however, receive a late question from a Mr. Jeffrey Smith. That question has arrived after the formal deadline, so we can't take it as part of the formal questions. However, it is relevant to item 11, and I have had the question passed to our health colleagues, so hopefully that can be covered off. The 2 points question can be covered off as part of that item as a benefit to Mr. Smith. Questions asked by members. Item 3, we've got 4 questions. We've got Mr. Phil King from the County Council, who's online. I can see Phil with his headset on in front of me. There's a question about car parking at UHL, and another one about the hydrotherapy pool as well. And then likewise from Rutland, we have Councillor Ramsey Ross, who has asked a couple of questions as well about ambulances and also about primary care. Each member will be provided opportunity, have been provided with written answers as well, but also will be provided an opportunity now to ask any supplementary questions or points for clarification. I would ask that those supplementary points must be about clarifying the information given to the original answer and not to introduce any new questions or any new points. And again, if I can request that those any follow-on points are as brief as possible so that we can progress the meeting. So over to you, Mr. King. Would you like to ask any supplementaries in relation to the 2 questions that you submitted?
Good afternoon, everyone. I hope you can hear me okay. Good afternoon, Mr. Morgan. Wish everyone a happy Christmas and New Year. What I wanted to ask as a supplementary, the first one is about the blue badge parking charges at the UHL, in particular at the LRI. And I'm not very happy with the answer I've received. It doesn't answer the specific points that I've raised, and I really don't think that's an adequate answer, Chair, and I really would like answers to the specific points I've raised with them. And the fact is that many users of hospital services are blue badge holders, disabled, or carers of disabled, long-term health conditions. So the fact that for nearly a year these charges have been applied and no one knew about it, I do think is quite, well, in fact, longer than that. And I find it quite shocking. And so I think the question is, I think the question that I would ask is, why haven't communication changes been made to patient communication, to the information on the display panels, in particular at the UHL LRI hospital car park, being made, given that in the answer it says that these charges were changed in December 2021, so that's 2 years ago, and there's still people who don't know about it and still putting the money in the machine and paying. So I think it's a very unsatisfactory answer, Chair.
Okay.
And if I can just move on to the second question. Colleagues might recall earlier this year in January asked a very similar type of question and was told that the cost would be 153,000 plus VAT. Very precise answer. And it will be put to the trust board for a capital allocation. And now we find that in the answer that the cost has now risen astronomically to £500,000 feasibility study, and it didn't get the nod in their capital round. Well, that's coming up to nearly 4 years. It'll be 4 years in March next year that facility will have been closed. And I'm just, again, doesn't really answer the question of, well, is there a plan to reopen this or not? Because there are many, not just were there voluntary groups using this, people who've got MSK conditions and other things as well, to try and help their mobility, so to reduce their burden on medication and on the wider NHS. But actually, people, patients are referred for hydrotherapy as part of their rehab on various conditions, and for them to go somewhere else is a long way. So I'm just kind of concerned that there doesn't seem to be any. I appreciate it's not the most glamorous of subjects and in the health speak, but again, Chair, I just think this is a very unsatisfactory answer. So my question is, when is this going to be sorted out? Because we're now coming up to 4 years.
Mr. King, okay, we've got that. We understand those points. We've actually got John Melbourne, who's the CIO of UHL here in the room. Excellent. So he's going to come back with those points. So if you want to go on mute, Mr. King, and then you can listen to John's responses to those.
Thank you very much. Thank you.
Thank you, Mr. King. So I'm John Melbourne. I'm the Chief Operating Officer at University Hospitals of Leicester. So firstly, picking up the parking points, absolutely, parking is free of charge for staff, patients, visitors with blue badges. We accept that the signage at the Leicester Royal Infirmary site in particular needs to be improved. I am sorry that we haven't given a timescale in the answer here as to when we will include that, and why I would ask, please, is that I could come back with a timescale within the next 2 weeks for when we expect increased signage. There is always a risk that people won't see that signage, but we need to do a lot more to publicise it, particularly at the LRI. As I say, we're very clear on our responsibilities since we reintroduced charging since after the pandemic, and so that is what I will commit to do for that one. For the second point about hydrotherapy, again, I absolutely understand this opinion. We re-looked at the capital cost of these works because of the complexity of the works involved, and that is part of it is a change of scope on the capital project, and part of it is because of the pressures on wider supply chains across the UK at the moment, where costs are increasing. We have, like many NHS organisations, an incredibly constrained capital programme, which has to be clinically prioritised every single year. And this is a part of that consideration process. It was not prioritised last year in, as I say, a very oversubscribed capital process, and it will be looked again this year, but I can make no guarantees within that. What I can say is, again, it will be a clinically led decision-making process that looks at all aspects. I am confident that patients are getting alternative evidence-based provision, so patients aren't being left with no provision here, but I do understand that that is a disappointing position for some people who would like hydrotherapy services.
Okay, thank you very much, John. Okay, so Phil, thank you very much for joining us. You're very welcome to carry on observing the meeting. Otherwise, if you want to turn off your video, otherwise you're looking like Big Brother above us, towering over the meeting. So otherwise, thank you very much. I'm going to move on to Councillor Ross now, if you have any supplementaries.
Thank you, Chair. Very briefly, I'd just like clarity around question 3, where it states this includes increasing our capacity. As you are aware, the ambulance service in Rutland already entails significantly longer times for ambulances, and it's really to try to understand whether this increasing our capacity will or will not lead to any further deterioration in the ambulance service in Rutland. And I appreciate that this is a speculative answer, but given that this event has occurred at the beginning of the winter, it's a reasonable question to ask.
Thank you very much for the question. So any ambulance handover delays are not acceptable in our eyes, and we want to get to a position where we don't hold ambulances outside our emergency department ever. That involves looking across a range of things, both within University Hospitals of Leicester and across the system, and we work incredibly closely with partners on this. Part of that is about increasing capacity. So, for example, we're opening a new ward at the Glenfield Hospital in February this year. We've opened additional same-day emergency care capacity. Our community colleagues have opened additional beds in the community as well. That is one aspect of our plan. We've got to make sure that we are more productive as a system as well, and we could evidence that with reduced length of stay on our medical pathways. And we have to make sure we're increasingly working closely with primary care, community, local authorities, etc. And I think we can evidence that to show that we are improving. Again, across the whole year, we have held ambulances for significantly less. I think one of the largest reductions in the country than 2022. What we've seen over the last 4 to 6 weeks is a really significant increase in admissions through our emergency department, which have caused some real pressures on our emergency pathways at the start of winter. And so we, as a system, are working incredibly closely. And again, we're meeting exec and chief executive colleagues last week and this week to work out what we can do more to make sure that we have a stronger winter this year than last year and continue the progress we've seen across the year. I am still confident that we will have a better winter than last year, but we've also got a lot more to do as a system. Again, I'll come back to we have evidence across this year that we are holding ambulances for significantly less than 2022, and the response time of ambulances across the system as a result are significantly better than 2022.
Thank you. And on question 4, this is really more a statement. I think it's generally accepted that the introduction of pharmacists into the system is a good thing, but it was accepted by the ICB at the Scrutiny Committee in Rutland that the communication of these changes has not been rolled out timeously, and it's really to try to get a commitment that I think this is important for all of our sakes in terms of understanding primary care provision and the role of pharmacists in it, and it's perhaps a rather more specific date in terms of when this will actually be done. Thank you.
Councillor Ross, I appreciate this probably might be a bit beyond John's remit on the basis it might be an ICB response rather than otherwise. But if John, if you're happy, either you can take it briefly, or we can ask ICB colleagues to take this back on outside the meeting.
Thank you. I'm afraid it is broadly beyond my remit. What I will say is there is a new chief pharmacist working across the system that has been recruited from University Hospitals of Leicester, and so that interface between our pathways across primary and acute care is really fundamental to where we need to go. I'm sorry I can't answer the specifics of your question today.
Councillor Ross, we'll ask colleagues at ICB to come back to you on that.
Thank you.
Thank you. Thank you very much for that. Okay, so those are the 4 supplementaries, and thank you very much, John, for fielding as many of those as possible. We're now going to move on to the remainder of the meeting. We are on to item 4, which are urgent items. There have been no notified items. Item 5, declarations of interest. Can I ask if anyone in the room has a declaration of interest pertinent to the items on the agenda? Mrs. Newton.
Got 2 family members working in the NHS.
Thank you very much. Any other points? Oh, yes, there we go.
I co-own a training and consultancy business that does work with the NHS.
Thank you very much on that. And also, Mr. Season.
I didn't realise I had to share this one. My daughter works for the NHS.
Thank you very much. Okay, I think that's everyone. Okay, that's great. Thank you very much. Right, item 6, presentation of petitions. There are no petitions, so we're on to the main items on the agenda. Item 7, which is the Care Quality Commission report into maternity services at UHL NHS Trust. Daniel Burnett, who's Director of Midwifery at UHL, is joining us, so welcome to you. And hopefully you'll be able to run us through. So we'll take the report as read, as always with all of these reports. Gives us an opportunity to get into the main meat of the discussions or any questions as quickly as possible. But if there are any brief points that you wish to make before we start questioning or making any points, then please do so now.
Thank you very much, Chair. Thank you for the welcome. Danny Burnett, Director of Midwifery and one of the Deputy Chief Nurses at University Hospitals Leicester. I'll do a brief introduction if that's okay, Chair. As members are aware, there was a focused inspection. It's part of a national maternity programme by the CQC back in February and March this year. The focused inspection just specifically looked at both the safe and well-led domain. It wasn't the rest of the domains that we're typically used to. And UHL were provided with an overall rating for maternity services as it requires improvement, and that report was published on the 20th of September. What it did describe in that report was an inadequate rating for safety and a requires improvement rating for well-led. Each site, so Leicester General, Leicester Royal and St Mary's, had their own report, and we know that St Mary's requires improvement overall. So lots of positive news stories in terms of what was coming out of St Mary's. As part of the report, what we also received is a Section 29 CQC warning notice, and that required UHL to make significant improvements in the areas around governance, risk, delays in care, as well as staffing, equipment, and the actions that were taken around equipment. UHL are taking this report incredibly seriously. The service is not yet where we want it to be, and where it needs to be. And we know that the improvements had already commenced ahead of CQC visitors back at the start of this year. We absolutely, from the bottom of our hearts, apologise to any families where our standards did not meet, where we fell short. We absolutely know that we don't get it right all the time, and we apologise to the families. Not having enough staff is the golden thread throughout the report in terms of the findings. And within the report, you'll see a whole host of actions that are taking place, specifically around the actions around the workforce, about how we attract the workforce to UHL, but also how we retain our staff. What I can report today is that we've had 57 new midwives join us since January, and we have recruited 9 specialty doctors. So it's been an incredibly fantastic achievement for us, and we continue to have midwives and doctors in the pipeline. So we have offers out on the table. So as we stand today for midwifery, for midwives, we have a whole-time equivalent of 36, which is the lowest it's ever been from a vacancy rate for quite some time. We know that our turnover rate and leaver rate is better than the regional and national average. So, like I say, the paper details several improvements that we are tackling in terms of the delays and access care for our families. So that's around the improvements we're making to our triage systems, the separation of telephone triage. So when a woman has concerns, that they are getting a really timely response at that point. Our separation of our elective and our emergency activity, so our caesarean sections, and the work that we're doing around induction of labours, which we know nationally has come out in terms of one of the themes from the CQC. So we have a whole project that's trying to improve the service, which means a new team as well. I know that if I was sat in your position, I would say, well, what's different? What's different now for UHL? I can honestly say that from a board to ward, we have absolute understanding of where our risks are. The support that we have from our execs, so John from an operational point of view, but equally our estates and facilities, our comms, our finance, we absolutely all own the improvement programme for maternity and neonatal systems. We have moved from reassurance to assurance, and I think again you'll see that in the themes coming out nationally and regionally. We have implemented, so what I mean by that, we've implemented additional sub-board level committees to ensure that we are receiving the detail and the evidence. Not only that, we're supported by NHS England and our ICB colleagues. So we have a quality review meeting that has an additional opportunity to present that evidence, and we act like a 3 lines of defence. We've had incredible amount of investment. So what we'll see again nationally is that the funding envelope hasn't been where it needs to be for maternity services. But what I can say is that UHL are absolutely committed. So we have increased our establishment to absolutely reflect what the workforce assessments are telling us. We've increased things such as our audit capacity, which from a clinical effectiveness will give us great detail in terms of how well we are performing. And we are optimising all the enablers, so such as our digital systems that we've currently got in place to ensure that we have real-time information. We are absolutely improving how we are listening to families, and we know that we have not always got that right. And one of the fantastic things that's happened this year is the new Maternity and Neonatal Voices Partnership, which is an independent body that's hosted by the ICB, but we've been able to build those relationships to get out to our communities to really understand how it feels to access our services. And we are making data counts. And it's not just about the analytics that are within UHL, but we're working with public health colleagues, not only across LLR, but equally regionally, to better understand our data. We are also strengthening relationships with primary care. We recognise when we talk about care closer to home, it doesn't just, maternity services doesn't just occur within UHL. So some of the work that we are doing with primary care, with neighbourhoods is absolutely critical. And we're truly leading on co-production. So we recognise we have been a service historically in maternity of doing 2, and actually it should be partnerships in care. So very much using user experience models. So they're just a few things that I wanted to highlight in terms of the improvements. I do feel that we have a better understanding of our risks. And like I said at the start, we know we're not getting it right all the time. And we absolutely want to be able to learn from all those examples that come to our attention and improve our services.
Thank you very much, Danielle. Before I open the question, can I ask very, very quickly, you make reference to a request to CQC to come back in and re-inspect, and obviously having an external assessment, to have categories of inadequate, undersafe, obviously, you need the CQC to actually be able to say publicly to you and everyone else that is now safe. Because obviously having this on the system is probably going to be a real concern for parents who are going to be using the system. How quickly do you think they're going to be coming back? Have they given any indication yet?
So no indication. What we know is we've got a Section 29A warning notice. So usually and typically it would be within 6 months of issuing that warning notice. So it could be any time within that period. And you're quite right, we do invite them back in.
Okay, good. Thank you, John.
Thank you. Just to be really clear to that point, we have said to the CQC we want them back in as soon as possible. We absolutely own, as Danny says, the outcomes of the report. We had plans in place at that time. They judge what the situation we're in at that time, not our plans. We are confident that the plans we have put in place are delivering improvements in our maternity services, and we know we've got a way to go as well. That co-production point and trust with our communities we know is really fundamental.
Okay, thank you very much. Right, over to you, Councillor, to start off with.
Good start. Thank you, Chair. Thank you, Danielle, for that. We have touched on this in Health Scrutiny in the city. The thing that struck me there was that both the general and the LRI required improvement or were inadequate in every single area, including being safe. And the bit of the inspection that was continued to have some green, and the bit where we weren't entirely inadequate was at St Mary's. and people who've been around on this commission for a while will know that there's been lots of talk about closing St Mary's. So my question is about that, and then the second one was I was really shocked to learn that we knew that they were coming and that this was a planned inspection, and we still did quite so badly. So given that we're inviting them back in, will we have some forewarning, and how can we be reassured, I don't know which, both, that we'll do better this time? How are we doing with those dates and timelines that were in there? For example, September 23 is referred to a lot. There's quite a few key deadlines that have passed, but there's not a clear update on how we've performed in those. And then finally, it's just a question for clarification, Chair, if I might. You talked about 36 vacancies. Is that the outstanding number of vacancies? Because the overall full-time equivalent, because it looks like that's, we had 48 full-time equivalent vacancies at the time of the inspection, and that's now gone down to 36. So we've only really taken a quarter of that off. So just some clarity around that. Thank you.
Thank you very much. So if I just take them each question at a time, and do remind me if I don't respond fully. So in terms of St Mary's, it was great in terms of the progress. I think what you'll start to see in St Mary's report is actually some of the positives across the General and the Royal as well. So it did reflect. There was the very public consultation in terms of where we are with St Mary's and the plans for the future women's and maternity hospital. And part of those plans is about moving the intrapartum care and having a standalone midwifery-led unit at the General site. And there's been no change in terms of the plans around St Mary's. What we can do now is absolutely capitalise and continue to ensure that we are, and I talked around the word optimisation, optimising the services that are currently available to us now, and St Mary's is one of those. So from a utilisation point of view, we know that actually the number of women and birthing people that access St Mary's has dropped over many years, but actually what we do know is the services that are there are safe and are in terms of positive experience, and we want to continue to ensure that St Mary's is still a positive experience for families using that service. So I think it's about learning what works well at St Mary's and how we can replicate that back at the General and Royal, and vice versa. In terms of the progress against the Section 29A, you're quite right in terms of the dates. There was the end of July, the September and the end of November to make significant improvements. Overall, with 64 actions that underpinned each of those sections. And we know that staffing, so the recruitment, was absolutely one of them. So you're quite right in terms of the numbers, the whole time equivalents for midwifery at the point that the inspection occurred. And actually during the year, we actually went up in terms of the vacancies, and then we've come back down significantly. So we know that 57 new midwives have started at UHL since the start of January, and 20 have left. So in terms of the turnover, it has been positive, and actually it's much better than that displayed nationally and regionally. And I can give the breakdown in terms of the reasons for leaving. So that be relocation, a career change, and in terms of some of the work that we're doing around the retention and the stay conversations, actually we're having a really positive impact. So we are currently today, based on our workforce assessment that is nationally, so independently determined, we are 36 full-time equivalents. We've got a vacancy for midwives only. So in terms of the wider progress around the Section 29A, we are progressing well. So the work that we need to do around our equipment, so our servicing of medical equipment, we had 100% compliance, and we was able to say that at the end of July. The challenge is sustainability. So it can't just be about ticking the box at the end of July, but it is about all the new equipment that's coming into our areas and the continuation. And we have a whole programme of work which we present both internally through our Maternity Assurance Committee, but then externally to our ICB and NHS England colleagues. So we are making progress in terms of all 64 of those actions, but the Section 29A warning notice needs to feed into the wider improvement programme, and that's the point that we're at the moment, because again it goes back to sustainability. are we ready? So I think it's just picking up on your point around being aware that there was a national programme. I believe and I know that we were aware and becoming more aware of the risk ahead of CQC. So actually, in preparation for CQC coming, we already knew. So my post wasn't in place. So from a director of midwifery, at that point we only had one head of midwifery and one deputy. We've increased the leadership in terms of the support. I think that the investment, not only in the leadership, but the estate and the facilities that has occurred in the last 12 to 18 months has been incredible. And that's everything from new curtains to, plaster being pulled back and re-plastering in terms of improving the estate, etc. John, if there's anything else that you want to.
Thank you. Just one point to add on it. So, of course, I can't remember exactly how much notice we got. There was a couple of weeks' notice for the inspection, and of course, we make sure we continue to do the right things. Much of what we're talking about here, like recruitment, like splitting elective emergency, like the digital work, it takes time. And since Danny's been in post 12, 18 months ago, it's been absolutely top priority for us as a trust. And so there were things we were able to say to the CQC. This is not in a position we think is good enough at the moment, but these are our plans to improve it. And that's what we have continued to do at pace over the last 12 months. And we'll continue to do that over the years to come.
I do believe we are improving. We're not there. So when CQC come in, I know that we will be able to show significant improvement in those plans that John's just mentioned, but I know that we're not there.
Councillor, I think you were next, and then it's Mr. Harrison after you.
Thank you. With UHL's commitment to recruiting midwives, and I think at our last meeting you carried higher vacancy rates, so you've got 36 that you carry now, but you're recruiting from the same pool, and it's really hard. We had last time that it was just a standing advert you have on NHS jobs. I just wondered why you aren't considering midwifery apprenticeships at all.
Thank you. And you're correct in terms of it being from the same pool. And I think particularly over the Midlands, we are very challenged in terms of our recruitment pool. We have also recruited from internationally. So we have 14 new midwives that we have onboarded, and we continue to recruit more so internationally. Apprenticeships we are absolutely exploring. We're exploring with both universities and colleges, and I would fingers crossed like to say that you will start to see updates around the midwifery apprenticeships coming our way within the next 6 to 8 weeks.
We have got anecdotal evidence that the retention rate of apprenticeships is far greater as well, plays into your attrition rate. 30% for nurses as opposed to 3% for apprenticeship nurses. So that would actually be something as well to really positively look at. And I think with some of the changes that are happening around the visa rules, recruiting internationally on lots of levels, I think there's issues, especially when you're looking to sort of create a workforce locally, but also it will have an impact upon that. So I think the sooner you look at apprenticeships, the better.
Thank you very much. Okay, can I just ask whether there are any other further questions beyond Mr. Harrison at the moment? I can't see any other hands up. So, Mr. Hills. Okay, so Mr. Harrison.
Is that on? Yeah. Thank you, Mr. Chairman. It's a very sort of serious report to read, and personally, I was shocked to think that it got to such a situation that it's sort of run down and run down. I know you were saying we were doing this and we're aware of that, but in the service industry, you've got to be ahead of the game. And you know that people will be having babies and the system works day or night, it runs virtually on its own, but the staff have got to be there and they've got to have the equipment and everything else. So that really took me back by surprise to see how badly you look at your new innovations, your new thought process. But I mean, clearly when they arrived in March, it wasn't there ready. And obviously their points. Now,
don't mean this disrespect, but it's easy to say, yeah, we're doing this and we're already on that one. I don't know, and only you know that, how far you were advanced. All I can say as an individual from a distance, just reading the report, it's fairly shocking to think of the levels, and then to hear how quickly now you've had your wings clipped. All of a sudden, you're now energising the recruitment at a level that wasn't happening, and you're now energising equipment appropriately and everything else. So well done for doing that, but at the end of the day, you were forced to do it. It's nice to see and hear from your initiatives to do things. The cynical side is say, well, I suppose you just turned a blind eye to it because of the cost factors and everything else, knowing the state of the business and how you operate. So I'm understanding of that, but I mean, it is very serious. And when we think there was only recently somebody dealing with children has been found guilty of X amount of deaths, it's terrible. And then there's 2 nurses been involving themselves in other, it just creates an uneasiness to the public, because the public should always have full trust in hospitals and in medical communities. And you go in thinking you're not good or you've got a problem, but hey, they're going to help me and put things right. So I think, you've got to just be really careful that you don't lose PR as well, because it's lovely to hear the good stuff, but you should have been ahead of the curve and planning it ahead and not letting it get to that point. But I wish you luck in what you're trying to do. Thank you.
Thank you very much for those comments. Firstly, I absolutely agree that our responsibility to build public trust in our maternity services, and indeed all our services, is fundamental, and we absolutely own that. We wrote at the outcome of the CQC report an open letter to the public across Leicester, Leicestershire and Rutland that explained the report and the outcomes of it, and that went in the Mercury and elsewhere to the public. What I will say, though, and I will defend this, if I may, the CQC did not energise us as a trust. We were energised beforehand. We have, as an executive team, I am very clear about that. Our actions and our pace have not changed since the outcome of the CQC report. We have, 18 months ago, we brought in a national leading expert in midwifery as our chief nurse, Julie Hogg. We brought in Danny, a leading expert in midwifery, within the last 18 months as well. That has created an energy around us and as a broader executive team about what we are doing. Of course, the CQC report has redoubled our efforts alongside it, but I can absolutely assure you there's not been a change of pace or focus as a result, because we had that beforehand.
Thank you. And just to echo, so thank you very much for your comments. And in terms of feeling disappointed, I think I can speak for all of our staff who are working tirelessly every day and come to work to do a good job and try their absolute utmost to give the best possible quality care. They were equally disappointed in terms of the report. However, they also saw some of the challenges that were articulated in the report about their everyday's experience of how it is working there, so such as the equipment. And I absolutely take on board what John said in terms of the energy and bringing a couple of us into the organisation, and it is hard to keep that energy up, and our job is to absolutely do that, to give a new perspective, to do it's an absolute must do or can do organisation. And that was one of the reasons, and one of the main reason why it attracted me to UHL. This is a staff group who absolutely care. They can see the improvements that they are required to do, and they want to be part of that. So it is a full commitment to ensure that we continue momentum. As John says, we were recognising and we knew the risks ahead of CQC. Actually, what that does, the report and the Section 29A, is it actually gives us a further anchor in terms of the investment, because we recognise the financial challenges that we are across health and social care, but it's really clear. So it gives us a support in there by having a Section 29A warning notice.
Thank you. Okay, Mr. Halls, you've got the final question.
Thank you, Chair. Thank you for coming today, Danny. I don't want to put a Debbie Downer slant on things as well, because it seems like, you know, you are taking it obviously very, very seriously. We've got a plan in place. It seems like a very quick slide down the rankings, though, where we've gone from last being inspected in 2019 and 2017, where everything was good, to now, out of the 2 domains across 3 sites, so 6 evaluations in total, you know, we've got 3 requires improvements, 2 inadequates, and just 1 good. So would you mind expanding first off on why we've had this sudden slide in quality? And my second question is around the Section 29A notice that's been issued. What is the worst case scenario with that? You know, what if we don't hit the targets? What if the improvements that we're expecting to see don't come through? You know, what if just 1 domain still requires improvement? What happens then to the department?
Thank you. I think that the sliding or the deterioration in terms of those ratings, so firstly, it's a different inspection regime. So, and the fact that it is reviewing the 2 domains, safe and well led, it's not doing all the domains, is important. That's not to say that actually we're taking this any less seriously, because that's not the case at all. But this is a national team, it's not our regional team. So it's making sure that we're not comparing apples with pears. And actually it's about responding and looking forward now based on the findings that CQC found during our inspection. It is nationally reflected in terms of this deterioration in ratings up and down the country. And again, that's not to say that I am absolutely not dismissing UHL's position or responsibility to be able to respond to what has been identified. So you're not a Debbie Downer. I think it's something that we are really clear about. We're taking this report seriously and we want to put the actions in to address that. We are on an ambition to not only get to good, but it's about understanding what it takes to get to outstanding. And that's about learning from others. It's about what good looks like. And it's about moving the service forward. I think part of the golden thread, which we've talked about within the report, of the reasons why we had the outcome, we've talked about the staffing. So it's about not having enough staff. And we are safely staffing the areas where we know we are most in risk, but we know that has a detrimental impact on the experience of care in other areas, because we're moving staff to absolutely preserve safety. So we know across our services, we have pockets that we absolutely need to concentrate on. So we're preserving safety, absolutely. And I would say that actually we've got a better understanding. So one of the things that we've put in is a twice daily tactical call. So twice a day, and if it requires more frequently than that, we understand where we are in those coming hours of our service, and then deploying staff, we're supporting, we're making tactical decisions all the time. That wasn't in place. We're approaching the service in a very different way. So I think, just to remind me what your second part of the question was. I mean, clearly it's CQC are our regulators. I can't respond for what CQC will do. You know, we absolutely need to demonstrate significant improvement. What we haven't done and what we want to do is see CQC come back so we can present our evidence, and then they make a decision about whether that's going far enough. We believe it is, and we believe that we've been able to present that externally with NHS England colleagues, as well as our ICB, our commissioners. And in terms of the confirm and challenge about whether it's going far enough, but it is regulatory action if we are not able to demonstrate that significant improvement.
Thank you very much. Look, thank you for members for asking those questions, and thank you very much, Daniel, for joining us as well, and for the commentary on the paper. Hopefully you can get the CQC back, and all of the work that's been put in and the changes that have been made can be reflected in a refresh report. So hopefully it's on the way up rather than actually Debbie Downer. I've learned a new expression today. I never actually had heard the Debbie Downer before. No, I've never heard that before. I know. Obviously, I need to circulate more, but there you go. Well, look, thank you very much for joining us. Thank you. Okay, we'll now move on to item 8, which is the restoration and recovery of elective care. Do we have Siobhan with us? We have, excellent. So we've got Siobhan now. Favia. Excellent. I'm normally completely mangled names, so thank you very much for that. Is Deputy Chief Operating Officer at UHL. So obviously John stays with us as well as the COO. So again, likewise, we'll take the report as read, but if there are any few sort of comments that you wish to support the report before we go into any questions or points that people wish to make. Thank you. Over to you.
Thank you. So I think overall, we've continued to see a reduction in those patients waiting the longest for elective care across LLR. As you'll see in the report, the shape of the waiting list, it shows that we're focusing on those with the longest waits. It's a very healthy shape, which suggests that you're focusing your treatment on the right patients. If it was more mixed, you'd see that you were selecting patients at lower weight than the higher ones. So I think that's really important to note. The tail of the longest waits are starting to reduce. That said, with strike impact and going into winter, we are seeing more cancellations. So that is having an impact on our trajectories for those waiting the longest for our care. However, we've got lots of plans in place, so we're doing what we can to maximise capacity to reduce those waits. So hopefully you can see that in the report, and I'm happy for any questions on that. We've also included in here some of the productivity metrics that we're looking at and monitoring. So we've increased things like theatre utilisation has improved. So it means we're maximising the theatre lists that we are running. So we're seeing more patients on them. And the average case per list has also increased, which is really positive. So it means that we're getting more patients through our resources. We're also looking at increasing our day case rate. So for urology, for example, we've improved the rate of day cases for those patient cohorts. Again, that's really positive. We're now one of the highest performers in urology day case across the region, which is really, really good. And we're also starting to make strides in orthopedics. We did our first day case hip replacement in November. So there's a lot of transformation work going alongside the day-to-day in order to maximise our resources and treat and see more of our patients. I'm happy to be asked any specific questions.
Thank you very much. Can I open with a couple of very short questions, and then I'll pass over to Councillor March. So a couple of points really, which is about clarification of who's included and who isn't included on the waiting list. It's great to see the numbers coming down, and clearly that trend has continued from previous meetings, and absolutely brilliant. Where somebody, for instance, is on an annual review, are they actually included in a waiting time? In other words, they've been seen, but they've been logged into the system to have another appointment or checkup in 12 months' time. Are they included, or are they actually on a completely separate list?
They're on a separate waiting list. It's called a non-RTT waiting list. So we monitor that too. We're not a national outlier for those patients, but we do have a significant number of patients who are on non-RTT waiting lists. Okay, so the list is purely new cases, diagnostics, treatments, surgery, in some cases in care, etc., etc. Yes. But okay, next question. We've seen in national press about some centres using parallel operating theatres to try and clear in one weekend as many cases as possible, with teams literally tag teaming between operating theatres, and the success on being able to clear some of the sort of backlogs, in particularly in specialist care. So they're all treating effectively the same people, but a whole list being shrunk in sort of one weekend. Are we? I mean, what are we doing as far as looking elsewhere to see best practice, to see whether any of that is actually relevant here? Because obviously our list, being the size of the UHL as it is quite extensive, and I suspect probably actually being able to clear some of those lists would be quite beneficial. Yes, so we're part of Getting It Right First Time, GIRFT for short, which is a national programme of best practice. So we're in cohort 1 for that, the first group of trusts nationally to be part of that. with those meetings, we meet regularly. There's 17 specialties that are supported, and you speak to other trusts around best practice in that area, what they recommend, which is all with clinical conversations, sometimes challenging conversations between different clinicians in different trusts, looking at actually what can be achieved and where, and how we can be better at some areas, and what can be improved. So those conversations are had at that level. We're constantly looking at looking outside and horizon scanning to look at what other places are doing and how they're doing it. We have looked at those super operating lists. They're not necessarily appropriate at the moment for us, mainly because those operations of low complexity. We don't have a huge number of those patients in the longest waits at the moment. It's more complex procedures, so you can't get that kind of throughput. However, we are looking at maximising our lists and scheduling to best practice. So, for example, moving to 4 joints on orthopaedics lists, doing 10 eyes on an ophthalmology list. So we are looking at maximising it that way, but we haven't done super theatre lists. We have done super outpatient lists. We saw 160 patients the weekend just gone in gynecology, for example. Same approach, but for outpatients, and we are doing that.
That's great to hear. Thank you very much for that. So I'm going to go Councillor Marsh and then Councillor Underwood, if that's okay. Oh, sorry, Mrs. Doctor, apologies. I have responded to Mr. Hills as well, who's also a doctor, but I switched between doctor and Mr. So
no, I'm not Mr.
No, that is one thing. Hopefully, I'm not going to get too wrong. Okay, well, look, we'll go for Councillor Marsh first, and then before I go any further.
Yeah, definitely not doctor over here. I did a double take on reading the original number, because my understanding, and people in the room will know better, but the population of LLR is 1.1 million-ish. So for 12% of them, nearly 130 odd thousand, to be on one of our waiting lists is the thing that took my breath away, and I had to just double check my maths on that, because obviously we all agree about the need to get that down, but that is more than 1 in 10 people is on a waiting list for elective care within our hospitals, which should highlight how important this is. In the context of that, there's some really good innovative stuff coming forward, and I definitely don't want to be a Debbie Downer, but and some, you know, you're kind of talking about day case hip replacement, which sounds innovative, and then just makes me panic a bit, because there's some stuff in here about patient initiated follow-up, or PIFU, or whatever, PIFU. There you go. Yeah, could be a Dr. C chair, but it strikes me as a recipe for inequality, really. And we talk a lot about in the city about health inequalities, and about how only the sharpest elbows people may be going to be following up their own cases, maybe going to be pushing, maybe going to be wanting to, maybe understanding when they need to reach out for some input from clinicals, professionals again. So there's something about what data are we tracking around that? How many patients and no longer seeing anyone at all following an operation? And what kind of demographic data are we collecting on patients involved in that PIFU process? And then also, as you were talking, Chair, if I might have a second question, third maybe, I guess I was interested to understand the involvement of the private sector in our work here to reduce these waiting lists. How is that impacting on the bottom line? Because I know the budget's the next paper coming up. And when do we think we'll be retreating back to kind of our own in-house NHS only provision, please? Thank you.
Okay, I'll try and address all of those, but if I miss any, please ask again. So the first bit about the waiting list size, it's significant, and it is staggering. Just a slight word of caution: you could have a patient, they're not 116 patients on the waiting list. It could be a patient is listed for multiple, but it is a huge waiting list. For day case, yes, that the person who was operated on is a healthy working professional person. There's only certain cohorts of patients that would be suitable for day case hip replacements. That said, we've worked really hard around the aftercare, and what we're doing in our day case unit at the moment is patients get a message, a pre-procedure follow-up, and there's a little questionnaire that they follow, and then if they need some support, that then allows a phone call to that patient, to have a phone call with a registered nurse to talk through what is concerning them, and there's a route in. So we are looking at that. A good day case can only happen if patients are confident in being able to access following their procedure. There's a bit of a confidence around that for the patient and their family, but also if something were to go wrong, then they need an access point back in. So we are working carefully on that. And around day case, there is a lot of clinical evidence to suggest that it is better for patients. I'm not a clinician, so I won't be able to give you chapter and verse on that, but it's better outcomes for patients. Recovery is better, their long-term getting back to where they were before procedure is much better. So it is the right thing to do, but it is something that we need to be cognizant of. Around PIFU, well done on the acronym. So this is around, for example, when you were talking about annual checks. It may be that a patient doesn't need an annual check if something's not triggering. So, for example, IBS is a good one. So people with long-term conditions with gastro problems, for example, we're probably all familiar with irritable bowel at some point of our lives. So that can be that the patient has a trigger, so then they can get access to a follow-up when they need it, as opposed to an annual check in February next year and they may not need it. No patient would be put on a PIFU without their consent and without a conversation with the clinician. So it would be for the clinician and the patient to decide it is appropriate. So it wouldn't be appropriate in all circumstances. That would have to be a careful consideration with the needs of the patient and the particular condition. So that is had at that point. PIFU is still relatively new, so we are looking at health inequalities, and I say more broadly, this is an NHS initiative, a national initiative, so we are looking at that, and as part of the GIRFT work that we're doing, that is a factor, looking at health inequalities, because it might be, again, it comes to sometimes confidence levels or access. Patients may not feel able to respond and say, actually, I need a follow-up, or I need to get in touch. However, so far, the information that we've got is it actually makes it easier. It can be very difficult to get back in touch with secondary care when you need it, and PIFU offers a route in, an easy route in. They can text message, for example, and then that goes onto a list that then is actioned by the clinician and the administrator. But it is something, as we're rolling it out, that we need to do more work on. Around, I think your third one was around private sector. So use of the independent sector has been a key part of our elective recovery. We've used the independent sector to increase capacity in a way that we would not been able to do just within UHL. So it has allowed a greater speed of elective recovery than otherwise. That said, a lot of the independent sector contracts that we hold, a lot of it is done at reduced tariff. So actually, it's cost effective for us to use it in many circumstances. But it is something that we need to look at for value for money, and we do make that assessment before we enter into an arrangement with a private sector provider. It's not always better to do it in-house. It can cost more to do it in-house. It's part of the decision making that we do when we're broaching independent sector to support us with capacity. So it is something that we look at alongside making sure that actually they're going to provide the quality of service that we expect and we need for our patients. their use of the independent sector has reduced over the last few months, mainly because we've reduced our waiting lists, but also the patients that we were sending out to the independent sector tended to be the lower complex patients, and actually the more patients on the waiting list and the longer waits are the more complex patients that need to be done within UHL.
Thank you very much. John. Councillor Marsh, do you want to quickly come back in before we go on to John?
Yes, please, Chair. It was just, it strikes me that the answer to my question is still being worked on around that PIFU stuff, and just a request to yourself really to kind of, when that data is, for the committee to be able to have sight of that, please.
I without a shadow of a doubt, will be coming back to this. So I assume that the update on PIFU will be coming soon.
Health inequalities within it, because what we wouldn't want is a whole load of people with sharp elbows being okay and a whole load of risk being put on those without. Thank you.
Okay, we will definitely come back to that. John, do you want to add any extra points before we move on?
Thank you, very comprehensive. Just a couple of extra points, because I had the ability to Google while I was Siobhan was speaking. Yeah, absolutely. So firstly, your point around 1 in 10 people across LLR being on our waiting list, roughly speaking, is one which we have repeated many times over the last couple of years as a motivating factor for our colleagues across the trust. So thank you for that. It's a really important point. It is quite stark. Looking at the national picture, the last published figures were 7.7 million people, I think, against a population of around 67 million across the country. So not out with the national, but also not acceptable. And I say that as a point. This is not me saying that is an acceptable position, but it's one which we absolutely use as a motivation. Nationally, you'd have seen that there are still a lot of news about the waiting list increasing. We are booking the national trend at the moment. We had one of the biggest waiting list increases in the country during the pandemic, and for us to see that waiting list come down in significant numbers over the last 12 months is really positive progress, and we don't accept our position, and we recognise we need to be sat here in 3, 6, 12 months with it further decreasing, and that to continue over a period of years, and that's absolutely our motivation. The second point around PIFU and inequality, it's a really fundamental point for us. Our Director of Health Equality and Inclusion works very closely with us on this. And what I'll say is most fundamental to me is this needs to be clinically and patient-led. This is not me and Siobhan saying you must hit 30% PIFU or anything else like that. It is your challenge is to get to the appropriate level for individuals and for your services. And frankly, it's not suitable for some services at all. So I'll not go through listing them, but some you need a regular check. Some of our cancer checkups, you must have a scripted check at a certain time, and that's fine. You would not have PIFU in that scenario. For some, it suits the patients and the services. So I'll give an example. I was speaking to a dermatology colleague, and they would say that their patients see it very positively because they can say, if you get a flare-up, get in touch and come back, rather than come back in specifically 12 months and you might not be the right time for you. So there is a place for this. We are very clear to be doing it very carefully and that fits clinical criteria and patient need.
Very much for that, John. Right, we've got quite a few questions coming up. So next one will be Dr. Underwood. Then we'll have Councillor Whistle. Then we'll have Mrs. Newton, and then we'll have Dr. Hills. So, Dr. Underwood.
Thank you. I've got a couple of questions, if I may, or comments/stroke questions. My first one is, on your waiting list, are you counting those patients who are waiting for procedures like radiotherapy? Because what I'm picking up locally is that people are having to wait longer, particularly men with prostate cancer are now having to wait 6 months for their radiotherapy as opposed to 3 months, the 3 months that it was a year ago. And that is causing quite a lot of stress for people. And my second point is totally disconnected, but is with your stopwatch notion. I think that's open to abuse, both by clinical staff and by patients, because if I suddenly started having a twinge and pain in my hip or my knee, I know that there's a long waiting list to get my hip or knee replaced. So am I going to go to my GP and say I want referring sooner so that I get to the point on the waiting list. When I get to the point on the waiting list, that is when I need my hip or knee replaced. So that's from the patient side. From the medical side, how much pressure is there on the clinicians to say, we'll just wait, we'll stop the, not telling the patient, but just sort of quietly stopping the watch or stopping the clock, as you've termed it in your presentation, and then putting them back on in 6 months' time.
Thank you. I might start and then I'll let Siobhan come in. If I may address the second first, it is fundamental to us. We will never do anything which is against the rules or against patients' best interests. So there is zero pressure from me as an executive in the organisation to do anything other than the right thing for the patient. I would not put pressure on anybody. In fact, quite the opposite, I would put pressure on people to do the right thing for patients all the time. We will never pressure somebody to close a pathway inappropriately. And forgive me for being so direct with that. It's a really fundamental point for me as an individual, regardless of anything else. I do, just as a follow-up to that, I don't want PIFU to be misinterpreted as a pathway stop. It is not. Your pathway have already stopped by the time you get to PIFU. So it is not a help to get waiting lists down. It is just a method to potentially free up more slots for people who need follow-ups, etc. But it doesn't impact that waiting list point. I'll pause on that point for a second just to check there's no follow-ups, because it's such a fundamentally important one to me.
And from the public's point of view of trying to beat the system to try to...
Yeah, thank you. So I don't know, to be honest. There is a risk that people know that we've got really long waiting lines, so they start to access primary care and other earlier. The way for us to address that is to bring down our waiting times, and for people to have increasing trust in us as a system to be able to bring down waiting times. I'd like to think with things like advice and guidance into primary care, etc., that we will continue to do that and we could evidence that. But yeah, forgive me, I forgot your first question because I was really paused on the stopwatch.
My first question was asking specifically about waiting times for radiotherapy, and particularly for men with prostate cancer waiting for their radiotherapy and having to wait a lot longer, well, double the amount of time.
Thank you. So we brought the broadest planned care update today. We have, we can happily bring a detailed cancer update alongside that as well. We still, like in our elective planned care, we have people waiting for longer than we would like. But in my most recent board report, which I presented last Thursday, we could evidence that we have an over 50% reduction in those waiting over 62 days for their care, which is our standard 62 days from referral to treatment. So that's seen it's around a 55% reduction over the last 12 months until October this year, and that reduction has continued over the last couple of months too. So again, we can evidence that people are waiting less long for their treatment across our cancer pathways in Leicester. I don't have the specific answer on prostate here today, but I'm very happy to provide that separately. We have that managed incredibly closely.
Could I ask that you look into that, because I've sometimes attend the local prostate cancer support group, and your prostate cancer nurses have actually said publicly that it's the waiting time has doubled due to the shortage of oncologists nationally, but I would like that sort of to be looked at and possibly addressed.
Thank you. You are absolutely right. We and pretty much most trusts in the country have a real challenge with oncology services. So there is how do we provide that appropriate ongoing treatment for people as well, which absolutely we know is top priority for us in cancer. Certainly increasing particularly our recruitment and thinking of new modalities of treatment for cancer services is a really fundamental point for us. So recently we've started doing home chemotherapy and using a mobile facility to be able to increase our provision there. We know we've got a lot more to do, particularly with oncological services.
Okay, thank you very much for that, John. Right, Jeff, you want to go next?
Thank you. A couple of questions about numbers on waiting lists again. In this paper, you quote the total number of people on the waiting list at April of this year as 117,000, And in the minutes of our last meeting, the number quoted was 133,500. Could you just explain the difference between the two measures that were being reported on? And secondly, my City Council Scrutiny Committee were fortunate that we had an invitation last week to visit the East Midlands Planned Care Centre. Only phase 1, which is a small new building, was open at the time, but they're already working long hours and getting a lot of people through. I just wondered if you could give an indication of when phase 2, the much larger part of the project, will be complete, and any idea of the numbers and timescales for when that will start to have a very substantial, we hope, impact on the overall numbers on the waiting lists. Thank you.
Good question. I will have to check what I put in the last report. This is from our tracking information. There can sometimes be a discrepancy because you can have validation later, but I'd need to check. I can't remember it off the top of my head, but I'll have a look. Where we are now, so April 117, and then in October we're at 108, and we're looking to be around 106 the end of November. So we have seen a reduction, but I could provide that after the meeting around actually what those figures were for the year. I think there is a graph in the paper as well that shows that waiting list. I would like to say in the appendix. It isn't, so I can provide that. Around the East Midlands Care Hub, so Planned Care Centre, the second phase is planned to be operational in December 24. So we'd expect then to see that we'll see more patients going through that unit then, which will be in time for winter. So I'm delighted about that. So we'll see a lot more patients going through. We are looking at recruitment, obviously, ahead of that. So we've got the clinicians in post and in place, ready to see that increase in patients for both outpatients and for theatres.
I've taken the ability to search well. So there aren't different measures. Sorry, there aren't different measures. April this year was around 117,000 on our waiting list. October 22 was around over 130,000. So I suspect it's the months that somehow, forgive me if we made a mistake with that. But October 22 around 130,000. April this year 117. We are now in the low hundreds.
Okay, thank you very much for that. Okay, Betty, do you want to go next?
Yes, mine's a very quick one. I do a lot of counsellor surgeries, and I get residents coming to see me. And one theme is starting to emerge more than it has ever in the past, is the impact of the waiting list and people actually coming forward for treatment. I mean, I've had some people, one woman in particular that's concerned me, and still trying to chat to her to go ahead with it. But whatever's going out there is deterring people from coming forward to get treatment. I wonder what can be done to prevent that happening even more. Thank you.
Sorry, do you mean from going through to primary care to then, sorry.
No. I don't know where the information is going out there about huge waiting lists, but it is filtering down to the public, and it may be deterring those who actually need treatment. That's my concern. Thank you.
I'm obviously very disappointed and saddened to hear that. Like John said earlier, that biggest thing I think we can do is reduce our waiting lists, and make it easier for patients to access treatment. We are sharing our waiting times with GP colleagues, which should help. So when they're having that initial conversation with the primary care practitioner, there's a bit of expectation management around the pathway, and so that they can have that conversation. We're also communicating more with our patients on our lists. Obviously, this is the patients who've come for treatment and are on a waiting list to be treated. So we're having regular communication with them, primarily through text message, where they have a mobile number, if not through letter. And so patients are contacted more routinely than they ever were before, around the fact that we've still got them on our waiting list. We still know that they're there. So we are trying to improve that. Around not going for treatment in the first place, I mean, it is very difficult. I think it's a very difficult environment at the moment, and a lot of the headlines are negative, and that will have an impact on our local population. I'm not sure how to get around that, but I think what we are doing is we're having a lot more conversations at as a board called Planned Care Partnership, which is with our system colleagues. It's got GP representatives, it's got mental health representatives on there, and we're having those conversations. So when we're doing communication out, we're cognizant of what other partners are doing, so that we can make sure that it's tailored appropriately. So messages for around PIFU, for example, we're looking at that with the GP so that they understand. So if they get queries back around that, they're able to answer those. So we're trying to be a lot more joined up and work as a system for that. And I think that the main bit is getting our waiting times down, and trying to make sure that patients get the best care they can when they come into our services. Don't think I'm answering your question brilliantly. I don't know if you want to add anything else to that, John.
Because it's part of, I mean, it's just like there are people talking to me about some of the stumbling blocks seems to be around when they go to the GP surgeries, and there's more negativity, whether it's meant to be like that or not, about taking it forward, whether the GPs are overwhelmed or what, I don't know, but that's what's coming to me as a counsellor, is the fact that they don't feel they can move it forward. Thank you.
Yes, thank you. So we are building much stronger relationships with primary care colleagues, who are of course incredibly busy, as are all colleagues across the system, to make sure that people access the right place. We're very clear. Our job is to get people to the right place for their care as soon as possible, and that's on urgent emergency care. If there are any scenarios where this person has had an unsatisfactory episode at our trust or anything, I'm very happy for them to get in touch directly with me if there is a situation that has discouraged them. I think we've touched upon 2 points here of people might not want to engage because of length of waiting lists, and people might want to engage particularly early. These are risks which we're very conscious of. We know we have differential level of engagement across LLR and different referral rates as well. And so we work with those specific primary care practices where we have particularly high or particularly low referral rates to try and encourage the right level of referrals for them. We know we've got more to do on this though. And the fundamental way is we build trust in our services and we bring our waiting list down.
Okay, thank you very much for that, John. Right, final question I think goes to Mr. Dr. Ross Hills.
That's it. We got the
sir, and I think that's the final question, unless anyone else put a hand up that I've missed. No.
There's one.
Oh, yeah, you've got the final question in that case, Mr. Ross. So, okay, Ross.
If it's okay, I just wanted to zoom in quickly on the Hinckley Community Diagnostic Centre. I was out on Castle Street in Hinckley a few weekends ago talking to residents about healthcare services in Hinckley and Bosworth, and there's almost universal support for the idea of a diagnostic centre, because a lot of residents just don't want to travel into the city of Leicester for whatever tests they're having. But as you'd expect, they wanted it open and ready as soon as possible, and January next year wasn't quick enough for them. So I'm hoping you can offer me some reassurance that everything is on track for the planned opening. I know it does say it is in the report, but there's two areas that I wanted to go over. The first one is getting planning consent, because it says it's up for the planning committee at the Borough Council on the 16th of January, whereas my understanding was that it should have already been sorted in November, December this year. And so I was wondering if you're aware of any delay. I may have misunderstood that though, so I apologise if that's incorrect. But I do know they've been having problems within the planning department at the borough, I think it was at Borough Council over the last few years. And the second bit that I wanted to touch on was the staffing levels, because we discussed the CDC in this committee, or the Leicestershire County Council's committee a couple of months ago, and it wasn't clear that there was a real plan in place to recruit staff. We've said today already that it's sort of the golden thread running through all of healthcare in all departments and nationwide right now is staffing levels. And if you're going to be offering a lot more services or doing a lot more tests, you're going to need a lot more staff, aren't you? And so I was just hoping you could reassure me that there is a plan in place. We know exactly how many staff members we need, and we're already on the way to recruiting them.
Thank you. So if the person you spoke to was saying, can we do it faster? Was it me you spoke to? Because certainly this is, we know we've got the East Midland Plan Care Centre, we've got the Hinckley CDC, we've got many other projects opening, and we're trying to do them all at real pace. The project remains on track. That's the update I can give you today. I'm not coming with any specific concerns. As ever, when you do a building project of this size, scale, complexity and cost, there is always risk. And if I was sat here to say there is no risk, then I don't think you'd believe me either. But the programme is on track. I have no reason to believe that we wouldn't deliver it by January 2025. As I sit here today, it remains a real priority for us. It's being led by a system colleague, Helen Henley, Director of Planned Care, who continues to do a wonderful job leading it. I agree with you, the workforce planning for this, and indeed other areas of workforce expansion like the East Midland Plan Care Centre is really fundamental for us. I think we are showing that we're an employer and we're a system that people want to come and work with, indeed from surrounding areas and within LLR as well. So we know it's a challenge to bring workforce colleagues in. We have a structure of work around this, not just at a project level like Hinckley CDC, but across multiple projects to make sure that we're able to increase our recruitment for these projects in the year ahead. More than happy to bring a specific update on these workforce groups, but at the moment, we know over the course of 2024, we will begin recruitment at pace for all of these developments.
Very much. Ramsey, you're the last question on this session.
Very quick one. Thank you, Chair. It's really just to invite you to outline any major new initiatives that you are going to be engaged in the coming year that are likely to impact upon the waiting list, because clearly the concern is how quickly this is actually liquidated, and it's public messaging and public confidence in the speed with which that is liquidated is important. Thank you.
Thank you. So we're doing our operational plan at the moment. We're just finalising it for next year. It will still pick up the key themes of increasing capacity, productivity and partnership working. So those are the three pillars, if you like. So within productivity, we're still looking at theatre utilisation, so trying to maximise theatre lists, see more patients on those lists. We're also looking at right procedure first time and in the right place. So again, looking at what activity can be moved left. So what activity can now, with advancements, not be done in a theatre, but could be done in a clean room. What could be done on our community sites rather than in main theatres in UHL, for example. And then by doing that, increasing the amount of capacity we've got to see patients. So there'll be a big programme of work around that. We've also got a significant outpatient programme plan, looking at trying to reduce DNA rates, for example, looking at templates, clinic templates across specialties and within specialties and individuals, making sure that we're maximising our clinic capacity. Looking at on-the-day cancellations to try and reduce that again, trying to maximise our existing resource, looking at new roles. So that there is a lot that we're doing to transform services.
Many things.
Many things. Yes.
Thank you.
Ramsey, thank you very much, Siobhan, for that. So, look, thank you for answering the questions and presenting the paper. May the lists keep on coming down. and we look forward to hearing you from you again, hopefully in a few months from now, with figures sub 100,000 and still heading south. So good luck, and may winter be kind to us all. Thank you very much for that. Thank you. Right, we now move on to item 9, which is the NHS workforce in Leicester, Leicestershire and Rutland. We have Louise Young, excellent, and also, who else do we have coming? Nameplates are appearing. Jennifer Goodwin. Okay, that's fine. That's fine, absolutely fine. Okay, look, thank you very much for joining us. Again, likewise, we will take the papers as read. I know, I think there was a slide deck that was attached to the material that we had. We're using that as background material because I appreciate there was many slides in there that probably were not directly relevant to the workforce challenge, but there were some that were obviously available. So we're just concentrating on the actual written report, not the slide deck, but that's there for background information. So if you'd like to say a few words, that would be good, and then we'll go straight into questions and everything else. Mr. Harrison, are you with us? That's okay. Right, over to you, Louise.
Thank you, colleagues. Louise Young, I'm Deputy Chief Officer for Workforce and People in Leicestershire, Leicestershire and Rutland Integrated Care Board.
Afternoon, everybody. My name is Jenny Goodwin. I'm the Deputy Chief Officer for Human Relations and Engagement at Leicestershire, Leicester and Rutland ICB.
Sorry, just allow me to pull out some headlines with the paper, recognising you've had it in the spirit of time. So essentially, in terms of the NHS workforce, I will make some reference to our non-NHS workforce, because in the spirit of our direction of travel, we are looking at health and care workforce, and that has been our commitment since 2018, when we formed the LLR People and Culture Board. So our workforce, as you've seen in the report, we have up to around approximately 76,000 workforce across the health and care, and the two significant categories of that are across our NHS two main acute providers, UHL and LPT, and the second highest category of our adult social care external workforce market. So that's really quite important to note. In terms of addressing some of the priorities and challenges, this isn't new for us. We've been doing this for a long time, and with some frustration that we've not necessarily achieved some of the outputs we've wanted to, but we have taken a slightly different focus this year, and I'll come on to the think tank briefly around how do we start to address the challenges and the priorities to deliver a sustainable health and care workforce for the future. So really thinking about that 5-year lens, and how we do that year on year. And we are coming at this from a collective solution, solving the problems together. So what can we do once well to have some impact? So in the paper, it references the long-term workforce plan, of which was published this year, and it's the first of its kind to have a workforce plan for the NHS, which is quite phenomenal. It spans 15 years, and of course we've also referenced the health and social care plan, the what can we do well once together. So the focus of the work we do in the Integrated Care Board, and particularly around the LLR People and Culture Board, is absolutely looking at that health and care and the population, of which many of our staff are, as well as being staff as well. The collective challenge we found ourselves in this year has been two of the challenges for across the entire workforce is the turnover rate and the vacancy rate that we have across health and care. And you'll probably note in your report that the social care turnover rate, and which is the data from Skills for Care, is significant. So hence the ability to actually come at this together. We held a strategic think tank in October this year to really bring together health and care colleagues, with local authority colleagues attending, our local councillors, and it was really to look at what, with the focus of in mind of how can we sustain, what are the priorities we can absolutely identify that we can deliver in year 1, 2, 3, and then so forth, to address and have a real impact on our staff in terms of retention, recruitment and turnover, and the wellbeing of our staff. So essentially the report walks you through some of the initiatives we've had in place, but it's probably really pertinent to say we know we've still got a way to go. We absolutely have got a long way to go. This year in particular, we've seen, you know, we've been trying to deal with the increase in substantive workforce, whilst also dealing with the increase in agency workforce, whilst also recognising the gaps in social care, etc. So, you know, it's a really complex space. I won't go through the work that's in the paper and the outline, just some of the priorities that we've got. But one of the outputs of the strategic think tank was to start to focus now on what is our collective challenge going to be, and really map out year 1 through to year 5 with the impacts we're aiming to have. And just before I pause, I'd like to give some thought to the committee around some of the opportunities that we are already starting to address. It's obvious that the health, the anchor institution is a massive priority for us across health and care. By that, I'm talking about routes to employment, how we keep employees engaged in employment, how we bring them back to work when they're newly unemployed, and we're just working collectively to start to draft out the Work Well initiative that we've had issued from Department of Work and Pensions, which gives us a real opportunity as a health and care partnership to start to address some of the challenges. There's other opportunities there in terms of how do we start, and we took a proposal in March this year to the People Board, local jobs for local peoples, and that does draw on both the apprenticeship element and also on how we utilise and build ourselves as a system and as individual organisations to be real promoters of health anchors within the community. Secondly, retention. So we have a ICS retention programme. This is critical for health and care. Whilst we've had 2 people promises and our key providers, our ICS retention lead has been working tirelessly with primary care colleagues and with social care to try and have some impact. One of the outputs of that has been a system induction programme to start to signpost people. But the other element of that is the 6 high impact actions around sense of belonging, making LLR a great place to work, how do we retain the staff we've got, and how do we build on talent, etc. And then it would be remiss of me not to talk about primary care quickly. We have had quite significant growth in primary care, and that's largely due to the additional roles reimbursement scheme workforce, which had last year up to £25 million invested. And that really starts to speak around the workforce transformation we need to see at the neighbourhood level. So key to some of this is the workforce transformation and how we start to really drive strategic workforce planning from a population health needs and a demand need as well. And there's some of the areas we absolutely do need to start to get into in the outer years. So just finally to say, one of the areas that we've taken forward in year was and announced very late in the day was the multi-education training investment plan, which was taken forward as a system lens. My team delivered that, but absolutely in collaboration and partnership with system partners. And we now have, for example, just to share with you some data, and I can share more outside of this meeting, for the first time a system education and training plan that has a 5-year focus. We need to tighten up in outer years, but next year within that, from an apprenticeship lens, and particularly looking at clinical apprenticeships, we've got 147 in the plan for April 24 next year. We're also doing a non-clinical lens where we're starting to look at some of the apprenticeships coming forward, such as digital apprenticeships, which we're launching in next year. I know our local authority colleagues are developing a commissioning apprenticeship. So there's a lot of opportunities that we're starting to build in, and that's seen in the longest sort of spell of time. So we start to really get a rigorous lens on strategic workforce planning, training and investment and education development. Thank you.
Thank you very much for that. Okay, before I open for questions, I can see Ms. Charles with her hand up already. I mean, it was a fascinating paper, particularly setting out the challenges, but also actually just saying, some of the headline figures. So we talked about sort of waiting lists being roughly about 10%. I think employed in health is actually over 10% of the working population in the area that we cover, which is, I mean, it's a staggering figure. It's actually health in that case is probably the number one employer by far in Leicestershire, Leicester and Rutland. So, you know, it has a significant impact from employment terms for the area, but also obviously, you know, it does put into context some of the challenges that you're facing as far as trying to recruit into it, but also who you're actually competing against within the area. So fascinating to actually see some of those figures put in context. Right, Mr. Charlesworth, you go first.
Thank you, Chair. Yeah, I think you've got a huge task ahead of you. You really have. I mean, an organisation this size, retention is always going to be a problem. Smaller the organisation, the better retention will be. So you've got a huge challenge. And I'm glad you're including the care sector, because they've got a probably even bigger challenge than you. I've just read an ONS report about the care sector and the changes needed there. And their vacancy rate is worse than yours, which is going to be a huge problem. Ageing population, more demands. I think there's new immigration rules coming as well, which I think are going to present a problem. The other thing is, I think we've been very short-sighted in this country. Recently, I think we've always chosen the easy option and gone outside and got overseas health professionals and staff, brought them in lazily. We've not encouraged our own homegrown people to come forward, which gives us a diminishing pool. So, you know, how you square that circle without limitless funds, I think is going to be tremendously difficult. So there's not a real question there, just a comment, but if you wish to comment back, by all means.
Yes, that's okay, I would do. So I absolutely agree with you. I think some of the challenges and you've outlined some of the responses we've been working through, and it isn't an overnight, as your comment points to. This is really challenging, which is why we have to look at our domestic workforce first and foremost. We know we've got the international workforce, but actually this is about local jobs, local people, local communities. How do we absolutely reach into communities, identify hidden talents, identify opportunities for apprenticeships? Key to some of this for us is going to be the population health needs and how that starts to really shape workforce models going forward, and I suppose paralleling that with the demand that we're seeing coming forward, because if we can manage some of the demand before it hits our acute sector by integrated teams, by our additional roles reimbursement, then we're starting to balance the system slightly differently. But that's a long-term aim that we need to really start to, you know, there will not be any overnight quick wins for us here, but we've heard from our colleagues earlier that there are some real challenges and some areas of work that's starting to progress. Yeah, absolutely.
Just come back, Chair, quickly. It's not just about money, it's about locality. And locality is very important in terms of workforce. So best of luck.
Thank you very much. I mean, it is a fair point, because I know those areas particularly where they've got, you know, population slightly restrained by having sea one side of you and land the other. I mean, obviously, at least geographically, we can draw from a wider area, but those challenges are very, very real. Okay, look, I've got a couple of names first. So, Councillor Sahu, am I pronouncing this correctly? I'm terrible with surnames. Are you sure? Right, thank you very much. And then we've got Janet to follow you afterwards. Have we got any other hands to go up? No, in that case, go for it. Oh, and Ramsey as well.
I'm going to ask apprenticeship questions. I think what concerns me, and it probably feeds into a bit with what the gentleman said over there off the back of the CQC, is that it may appear that you're playing catch up to the long-term workforce plan. So obviously the long-term workforce plan has come out. It's littered with apprenticeships in there. Apprenticeships have been out in their current guise since 2017, and UHL have been very slow. Feeds into what you were saying about international recruitment, not looking at the homegrown, and therefore you are where you are. You talk about your largest number of gaps are in nursing and healthcare support workers. I'm not aware that you're doing anything around sort of topping up your nursing associates to becoming registered nurses through the apprenticeship route. Again, that's a very easy, quick win way to do it. I'm worried that you're waiting for funding to come out from the long-term workforce plan, which is why you haven't done anything yet, even though your agency costs will be really high. So it would be good to try and see that you're sort of a bit more proactive in that space rather than waiting, because we know NHS England can take a long time sometimes to sort of throw the money out. And I think you mentioned 147 clinical apprenticeships, and I'd be interested to know in what in.
Yes, sorry. So I will try and address those points. Forgive me if I slightly conflate some of them. But so in no particular order, we have got, from an agency lens, we have got very rigorous financial controls in place, and we are having weekly meetings, both internal within our provider organisations, but also from a system lens, trying to, we now have a weekly return to send back. So there's a real focus and rigour around the agency reduction, and I'm pleased to say we have had some reduction from the start of the year, and that's mirrored with an increase in substantive. So recognising the benefit to all, that if we can gain our substantive staff, we can reduce the agency. In terms of the TNA, so there's a lot of work going on in our acute trust and at system level around growing our workforce, and that isn't new. That's been in place since the long-term workforce plan a couple of years ago, and prior to that. So one of our colleagues in UHL head up that from a system lens, which is how do we grow our workforce, not just by numbers, but by skills mix. So, you know, the opportunity to grow our own, etc. And we have, as part of that, the healthcare support worker scheme, of which covers health and care. UHL have had a big increase in that this year. They've absolutely championed that. And we have some challenges in LPT with regards to how we're getting the bums converted onto seats, so to speak. In terms of training nurse associates, we have got 185 identified for next year for the plan. How many of those, I recognise the comment you're saying with regards to are we waiting for the funding? I haven't got the detail on some of that at the moment in terms of how many we've got in year with regards to apprenticeships, but I'll happily take that back and come back to you on that. With regards to the what are the apprenticeships in? So the clinical apprenticeships cover training nurse associates, advanced clinical practices, radiographer, mammogram. Thank you. Health visitor and physician associates, and medical physicians. And I'm happy to send the detail outside of this meeting with you to you.
I think what's interesting is that we're talking about you being low in nursing, and you've not mentioned nursing in there. So, you know, you've got you could top up your nurse associates to become registered nurses. And I didn't hear that being mentioned in there.
So the training nurse associates, we've got quite significant.
No, I'm not talking about training nurse associates, but about registered nurses.
Yes, okay.
Registered nurses. So I would be really keen for you to look at that route, because you've got a huge pool of nurse associates that could very quickly become registered nurses through the apprenticeship route, and you're not utilising it at all.
Okay, I'll happily take that back. Thank you.
Thank you very much. Come to you in a bit. Mrs. Newton, I'll add you to the list. So we've got Dr. Underwood first, then we've got Councillor Ross, and then I'll come to you, Councillor Newton. So Dr. Underwood.
Thank you, Chair. First of all, mine are more comments and questions, but the first one is I happened to watch this morning the Panorama programme on iPlayer, which is going to be on this evening live, and is looking at the abuse of people working in the social care system. It's looking particularly at a nursing home in the north, but actually it's a very resounding, very powerful lesson, and particularly the abuse of immigrants and the pressure that they're under. And I would really recommend it to anybody here who's concerned with the workforce. My next comment is really about entering and leaving the nursing profession. As a retired nurse, I think I feel quite qualified to say this. I was actually at the meeting, the workshop about workforce in October, and I was talking to two people who come from De Montfort University, and they're involved in recruiting and teaching students that have gone full-time into nursing, and they told me that their recruitment numbers have dropped drastically. And I think some of this is because of the cost, the fees, etc., that students are having to pay, and the fact that they're coming out of their degree with large debt and to a fairly low salary. And I think this is something that is probably deterring people from entering nursing. Also, I know that finding placements for student nurses in the clinical areas is difficult. They can't always find places for student nurses to go and do their training. And then at the other end of the scale, and I'm talking from personal experience, I know, but as people are expected to work till they're 68 now, as you get older, the physical challenge of working on a busy ward becomes harder and harder, and nowhere can I see, and I've been flagging this up for some time, nowhere can I see any consideration of an ageing workforce and how their lives can be made easier to carry on working for longer. It's absolutely exhausting on a full-on acute ward in a hospital. So they're my comments, really.
Thank you. I won't come back to all of them, but I will say, and I'll happily send, pick this up as well outside, but I will say from an ageing workforce perspective, we have been doing quite a bit of profiling. One of the things that we have got in January's People and Culture Board is a paper on the retention work that's happened across the year. One of the strands of the retention work is retire and return, or how we look at potentially redesigning jobs so we absolutely keep the professionalism. And as you say, people who've got years and years of experience, retain them in a system, but recognise that what they're there to do might change slightly. And part of that will be some of the work going forward. We've not yet scoped some of this because the report's due January, but how do we retain ambassadors? How do we retain the skills of an ageing workforce into the health/care space? And I'll happily come back and at some point when it's relevant, because I think your point's absolutely key.
Can I just? Please do come back to me. Thank you.
Thank you very much. Okay, we're now on to Councillor Ross, and then we'll come to Councillor Newton, Mrs. Newton, sorry.
Very, very quick one from me, and in part it feeds into what Dr. Underwood said. We recognise that absence and staff turnover are critical to having a stable workforce. Forget recruitment, that's additional too. We need to stabilise the workforce, and we need to address absence. And I was looking at two things in your programme, and the first one was the active bystander, which I found truly shocking. That there are deep-rooted incivilities in the workplace. I thought that was an extraordinary statement. I haven't seen that in many decades, in fact. And that then brought me to the position. This will sound slightly perverse, but the position of where culture and leadership programme is in your list. We all know that leadership starts at the top. And in terms of prioritising your different programmes, I would suggest to you that you should actually look at how you actually prioritise these and how they actually come across to people like me. And I don't come from the health sector, I come from construction and engineering. But those things are extremely important. I'm very glad that you've felt honest to put that in the public domain, but it is truly a shocking thing. Thank you.
Thank you for your comments. In terms of the culture and workforce programme, the list you have in front of you is not a prioritised list, but I recognise what you're saying. We fundamentally understand that the culture is key to the change, really, and the transformation. And so there's a lot of work going on around the culture at system level. So you're right, but I will take that point back, because I do think we need to ensure that when it's in the public domain, it's absolutely raised in terms of its profile. And I'll happily share with you some of the detail around that programme if that would be helpful outside.
Thank you. Thank you.
The second point about the active bystander, this is something we're doing locally to
I can't comment on the deep-rooted incivilities as such, but it's about enabling and empowering our staff across the system to be able to raise concerns. So we deal with civility and we deal with respect as part of our retention strategy and a sense of belonging.
Thank you.
Thank you very much, Ramsey, and thank you very much for that. I think the last question, I know we've got Mr. Newton as well. So Bessie, if you want to go first, and then we'll go over to Mrs. Seaton.
I have to declare I have family members working both with LPT and within the Royal Infirmary. I was a bit perturbed about looking at the turnover of staff and the very fact there's highest turnover of staff in the Royal Infirmary and better retention at LTP, whether it's working on wards or not. Can you tell me why there's such a discrepancy between the two? Yeah, in terms of turnover of staff. Some actually moved to LTP from the Royal. Do we know why?
The retention figure, so when we have staff move, we don't necessarily classify them as leaving because they've moved within the NHS family. Opportunities, I guess, promotion, and I'm probably not the best to be able to talk about organisation level data, but I can take that back as an action in terms of why they move from one to the other. I will say that from a retention perspective, given the work that I alluded to earlier around the retention programme across the system, that has seen, and it's in the packs, but it's seen a real change in direction from our staff across health and care, but particularly across the health sector, where we've seen some positive, slow and small, but positive outputs to the retention work. So that's given us some confidence that the work that's actually underway is helping.
It's fine. It's just I was sort of a bit concerned about how things were working out in terms of turnover, because you've got really good qualified staff. As I say, I know some are in my family, but it seems strange that you got this high turnover.
I'm just going to chip in from a practical perspective, because as a system, we actively encourage each other across all of our partners to retain absolutely what you're describing, the staff that have got incredible skills across the patch. So the more we can keep them within what we call our health and care family, the better. So often in regards to development opportunities, people who might be looking for something after them doing it for a number of years, we've touched on the fact that people are aging and they might be looking for something different. All of those conversations are actively encouraged across our system, and we have all sorts of places for people to do that on every sort of level. So there's an element of that within it as well as much as people looking for different things. So yeah.
Thank you very much. Okay, so I think final question on this item is over to Mr. Seaton. Brenda, do you want to go next?
Thank you. Like your colleague earlier who was Googling, I've also been Googling. And so my question or my request is for information. It comes from complete and total ignorance. Although my daughter works as she's neonates in education, so she's a nurse and she's been through the whole system. She's now in her mid-30s. So when she started, it was you didn't have to pay fees and she had a bursary. So I'm not sure now what nurses do get, or so really I'm asking you because I don't know whether we all know whether these bursaries, or we might not know that they were there in the first place, still exist. I've just Googled one and they said, oh yes, you can get up to 5,000 a year. And I thought, I'm sure bursaries don't exist now. So then I went on the government line and it did say that if you were a dentist or a doctor, you could get a bursary. And then it said something about nurse. So it was very confusing. So I would just like to know what happens. Do nurses not get any help for anything these days? Well, if somebody can, that would be good.
Louise, do you want to have a stab at this first?
I don't believe they do, but I need to go back and check. But I think I saw some head shaking over.
And is it in the gift of UHL to offer a financial assistance if somebody wanted to as part of your retention there and encouraging people to join the profession.
Can I just say this would be apprenticeships? That's what that financial offer is.
Yeah, apprenticeships, I think, is a good answer to all of this. Janet, do you want to have a quick yes or no? Do they get bursaries?
Very quickly, my understanding, but it's probably a bit outdated, is that students that go to university to do their nurse training have to pay fees and do not get a bursary. However, if people choose to do an apprenticeship and they receive sponsorship from their organisation like UHL or LPT, then they will get their fees paid and will also have a salary, is my understanding, but I may be wrong.
Okay, I think in that case that this might be a bit more for another paper, because by the sounds of it, there's a bit more discussion to come probably on all of this. Mrs. Seaton, is there anything else? No, you're quite happy. So
no, that's fine, but it might be the answer why you are struggling so much, and not just you, the whole country, in getting nurses into the profession.
I think it is also true. I mean, the point that I started off with, which is actually that the size of health in any geographic area in the country means that actually, the health sector as a whole, whether it's for nurses or oncologists or radiologists or social care, etc., the competition on places is so intense that I suspect you probably have to try particularly sort of every sort of turn and favour that you can to try and actually recruit into a particular area, to try and actually the point I think Mr. Charlesworth made about the sort of geographic area of trying to actually make sure that you're competing against other people successfully to actually recruit the staff that you need.
If I could just come back on that point, because I think part of the multi-education training investment plan, METIP, and the long-term plan has seen an incredible focus on apprenticeships, and I think that's a direction going forward. It's a new thing for, as in the METIP is new for us as a system. It's happened individually at organisations, so there'll be a lot more rigour and focus on that going forwards. But I tend to agree, apprenticeships would absolutely be the way forward. And also, once we've got the apprenticeship in, the idea is that they're guaranteed a job at the end of it, because we don't spend the time training to then not appoint. So yes, but I agree, probably one for later.
Okay, I think maybe.
So therefore, Chair, can we have something later on then?
I was just going to say exactly that, Mr. Seaton. You beat me to it. I was going to say I think it would be useful maybe 6 months from now to maybe have a paper coming back purely on the basis of apprenticeships and the way that they actually work, specifically in relation to, because we've had nursing in particular raised as to how we can be creative about using apprenticeships for the benefit of the organisations involved. I think that would be helpful, but we'll give you a bit of time to actually come up with some of that.
Happy to. Thank you very much.
Thank you very much. Okay, look, that's really good. Thank you very much. Thank you.
Can I just do a quick plug, if that's okay? In March, there will be a system joined up recruitment session again. You might have remembered they did one last year. So just sort of flagging it here with all of you to say, I know you're always very good at offering your help in getting it out there into the local communities that we've touched on. So we'll absolutely keep you all informed. And it is a system-wide health and care approach. Everybody's coming together. So we want to maximise the opportunity within that. So just wanted to raise that here. Thank you very much.
Thank you very much to both of you. Well done for the plug. We'll do our best through social media and everything else. Thank you very much. Okay, we'll now move on to item 10. I appreciate we're 2 hours into the meeting, so we will press on. We're on item 10, Integrated Care Board Medium-Term Financial Plan. We have Robert Toole, who's joining us, and I think it's Spencer Gay as well. Yeah. Excellent. So by all means, take seats. They're probably nice and warm by now, on the basis they've had plenty of use. Again, we'll take all the papers as read, so no need to go through them in line by line. But if you want to take a couple of minutes just to flag up any particular key points or any issues that you wish to focus on or draw attention to, by all means, please do. And then we'll go straight into debate and questions. Over to you.
Thank you very much. So I'm Robert Toole. I'm the Chief Finance Officer, and Spencer will keep me right if I go off some of the detail, if that's okay. So I think in September, one of my colleagues, Sarah Premmett, brought forward the 5-year plan that this committee's seen. And basically, this is just to cover some of the financial outline of that plan. just so that you're all up to speed as to that. So we presented that in October, and what we were asked to do is just talk about how we manage the budget over the next few years, particularly I think in line with both inflation, the growth that we're seeing in certain activity, particularly in our urgent emergency care, but also how we move more into prevention and rather than treatment is one of our key aims, so that we're looking at the longer term benefits for the population, which is one of those challenges when you've got the day-to-day pressures that you're facing. And also looking at the level of efficiencies or cost reduction that we need to play out, because it's always, the NHS is very good at adding services and additional activity, but it's very hard to actually look at care pathways, which is what we really need to do to actually get people looked at the right time, at the right place, rather than reliant on our hospital care, which of course we know is more expensive, although you may get the full service treatment there. So that's the paper in front of you. So we published the 5-year plan. Main principles, particularly now that we're working as an integrated care system, is to look at the wider aspects of how we spend the total allocations that we've got in new growth funds across the system, as opposed to just looking at each particular organisation's financial position. So we are trying to see how is it that we can work better in using our funds that actually benefit, as I said, across the entire pathway, rather than just within an organisation focused on its own requirements. We still need to set aside efficient funding to look at activity growth and cover costs of inflation. So, for example, you had a discussion earlier around the CDC at Hinckley. You know, that will require more staff, which is above and beyond what we've currently got. Obviously, that opens up opportunities for more access to services, but at the same time, we've then got to find ways of making sure that we can provide the treatment to those patients and the population that arrives. In order to do that, what we also need to do is become more productive and efficient. So productivity is better utilisation of theatre sessions, for example, and outpatients that we've already got. It's not about just increasing capacity, it's about using those to the full extent. And the other thing, what we've really got to look at is when people just talk openly about waste, but that's, if you look at lean methodology, that's very much about taking out non-value added activities, which with a number of handovers you get between NHS organisations can take quite a bit of resource up. So we've got to be looking at that as the benefit for the system. We obviously build inflation in. We have had our challenges this year on inflation, particularly around prescribing, where we haven't been able to get hold of drugs at the normal rate that we would expect, and I've had to look at alternatives. That's one of the drivers for main challenges this year, as well as the continued activity in the urgent and emergency care section. But we try and work that into our 5-year or medium-term plan. The aim is within 3 to 4 years, although this is quite a challenge because it's a 5% improvement in effectiveness efficiency, is to bring the system back into balance at that time. So at this moment in time, we are, so month 7, we were a 71 million deficit year to date, where we have a year-end target of only 10 million. So you can see the challenge we've already got in actually getting to that sort of level. Now, we may have had ambitious plans at the start of the year to do that, but with the scale of the inflation that we've seen above and beyond, and also the scale of activity and demands on the urgent emergency care, whilst we've also been working on planned care and driving down wait lists, that's meant we've got quite a gap between where we wanted to be and where we currently are. To that end, the NHS has been issuing out some more allocations to help support the position. So it looks like we're aiming for a steady state of where we are now to the end of this year, but that still means we've got to be more productive than we have been for the first 6 months, and we've got to manage all the winter pressures. And I think if that's okay, Chair, I'll halt there for the minute.
Thank you very much. So a couple of quick questions before I open up to various people who are putting their hands up already. So you touched on inflation. The figures that you've allocated for inflation within, I think it's item 6 on your report, obviously for the rest of us actually look very low compared to the sort of inflation figures that we're all familiar with at the moment.
That's true.
And is that something that is weirdly specific to the health sector, that the inflation figures are very low, or are they just slightly lowballed to make the MTFS work? Second point, which is about the 5% efficiencies, I've yet to see an organisation manage to actually find 5% efficiencies particularly in the sort of complex organisation that you're operating in. Again, is that 5% purely to make the MTFS work, or is there a plan behind it? And in which case, is the plan going to be published at any point for wider scrutiny? Can I just open with those two, and then we'll go to Mr. Richardson. I think I saw Mrs. Newton. Anyone else? Mr. Hills, Mr. Ramsey. Sorry, Mr. Ross, Ramsey Ross, and then Dr. Underwood. So we've got a whole list of questions.
Thank you. So for the first one on inflation, the table there is very much what the NHS issues out normally as part of its planning round, and that is what is used for all of the modelling going forward. It does occasionally will adjust those or will make additions. So for example, we have seen an allocation out this year to cover the costs of the industrial action that we've had, and also towards support some of the inflation. But I think it's also recognised, as you say, that that's a point in time. And that's what's in our model at the minute. If they're nationally, they provide different ones, and we're still awaiting next year's allocations, that will be updated. So at the minute, it's not specifically so that it drives the MTFS. That is the national planning assumptions, which everybody's expected to adhere to. That's that one. In terms of the efficiency, you're absolutely right. I think there's nobody, the NHS does not cut costs in that sense. It is very difficult to close or to remove services. I think what we'll be looking at instead is how we can actually, and you'll have heard the phrase, I'm sure, left shift. So we're trying to move, instead of having, as listening to West Streeting this morning, it's about £400 if somebody turns up in A&E. Why? Because they're having all the tests, all the bloods, and all the different staff looking after them. Whereas if you can turn up at your GP, it's a much different cost for a GP consultation, who hopefully is a one-stop shop rather than actually all the extended costs. So those are the sort of things we're trying to do, which is why we've got a real focus on what can we do more in the community, nearer the patient at less cost, but still providing the right care, than it is of actually having people get to a state of such illness or requirement of treatment that they need acute care. So hence the prevention agenda as well as the treatment agenda, if that makes sense. So we need to be moving that. And that's why we've really got to focus as an ICB also on children and young people services, because if you can help people coming through to more healthy habits, eating, etc., and good mental health education, that makes a real drive through their adult life onwards. So that's where we're trying to get ourselves to with all the day-to-day pressures we've got.
So on that point, because clearly the 5%, from what you've outlined, it is covering quite a fundamental shift in the attitudes and delivery of healthcare. Otherwise, it's going to be unachievable.
It is. The other thing we're trying to do, sorry to not mean to interrupt, apologies. Learn how to use it, sorry. Is clearly there are still funds that come into the NHS in terms of growth, and what we have to decide is, do we actually play that out in terms of, is it real growth in activity that we would then have to fund because we're putting more resources in, or is the opportunity to actually help with the services being run more effectively and efficiency, taking out that waste that actually means more people can be seen per list or through theatres or at outpatients. So there is that sort of balance between, as I said, cost cutting, but actually more effective use of the resources we've got. That can add up to the 5%, as well as not issuing out any new growth funds that we've got or any additional money that comes in for particular activity. So again, don't want to be building costs in. We want to be looking at how we can use that to change how we currently operate with the resources we've got, because we know the resources aren't infinite.
Okay, I'm going to open up to everyone else now. Mr. Harrison, do you want to go next?
Thank you, Mr. Chairman. I noticed the deficit of 70 million. And I recall, was it a year ago or so, where there was about 150 million discovered deficits, and I was alarmed and said, well, how are you going to handle that? How are we going to pay that back? And I was then politely suggested that government just wipes it out. So I presume that's the same with this now going forward. And I just wondered how the incentives is from government and your own organisation, because obviously if that ability lies there, you're not unique. I think everybody does. And so obviously, nobody really understands the true funding because of all these magic procedures that can happen that people from a commercial world just couldn't contemplate that happening. So it obviously gives you confidence in a lot of ways, knowing that there's a stop there for you in that respect. But I'm impressed if you are trying to look at it, because when you look at a 2 billion, Mr. Chairman, as a salary, as a cost to run the business, the percentage here and there can be quite phenomenal results, which I would assume that in your business, as costs are just going on because of people's age and the country's population growing, so the whole thing is sort of, you know, it's not so much a perfect storm, but it's the evolution of how we are, and you've got to be able to go with it. And obviously government's not going to be able to say, well, we're going to top you up just in case. They're going to run you to a tight line. It's up to you to try and do your juggling. But I wish you luck with it. But if you could just confirm that whatever that is, it is wrote off by government and it doesn't go on forever and ever. Thank you.
Thank you. I think strictly speaking, it's where organisations or ICBs or providers or whoever in the NHS makes a loss, then it doesn't automatically get written off. Yes, it may be supported, but it does go on the arguably the Treasury and the government's bottom line. So you'll see in the accounts for all of our systems a retained deficit carried forward. Okay, so that it isn't just wiped in that sense. It may be supported in the short term, but I have to say that this year in particular, over the last few months, there have been some quite I think challenging discussions between Treasury and the Department of Health as to the spending and the requirements for the NHS, with therefore a lot more scrutiny and desire to see and be ensured that financial controls are in place as well as they can be. And that particularly relates to our agency spend and actually recruitment of workforce, because that's key. And I think you've had just quite a debate about that, but that is one of the key areas where we have to have, as far as we can, a substantive workforce. Why? Because you also get the benefits of the team working, the consistency, but also it's at a value that is better than if we've had to bring in additional resource and staff at the last minute, you know, at a premium. So that's where we're looking at. But I think it is a challenging one. It's not a blank check, but it is something that it's challenging for clinicians in particular that want to make the right decisions for their patients. But actually, we all have a fiduciary duty in the NHS to actually make the best value for money decisions as well. And that's where I think we've still got work to do, but that's what we aim to do.
Thank you for that. It was a lot more professional than the write-off version, which stuck me. I thought, wow, okay. So I understand that. It is recorded, but there is no interest paid, I assume. So that's not accruing and growing that debt with the Treasury. It's there as a one-off against your books as evidential. Probably they use it for them when they're looking at how they're going to grant aid you in the future, and they're looking at how much you really do need as opposed to what they think you need. Thank you.
Yeah, there's no specific interest on the debt. There is, though, a thing called a public dividend capital that is calculated based on your, I haven't got, I'd have to go back to my textbook, I'm afraid, to answer that one. But there is a charge for having effectively a loan from the government, which is in there, but it's covered under a thing called public dividend capital. It's about 3.5% a year. It's a fixed fee based on a number of things. Can't quite remember. So there is a cost of borrowing, let's put it that way, although it's not excessive. Yes, Spencer, help me out here, I think, on this one.
Could I just ask, Chairman, is that then you have a figure, the Treasury, all of these hundreds of millions and tens of millions are all stacking up somewhere, and there's a 3.5% accrual, but it's never charged. But then that pot's just growing infinitely, isn't it?
Discharge, Spencer.
Yeah, that Robert's just talked about applies to cash and capital funding that comes into the system. So when we run into a deficit, we obviously start to run out of cash. So when we need to borrow additional cash into the system, that's when the PDC becomes applicable and charges get levied on that. In terms of the deficit itself and the revenue deficit, we've not in the past needed to pay it back when it gets written off, to use your words. But there is always guidance that tells us that we will need to do that. So the current guidance tells us if we were to deliver a deficit in 1 year, it will be paid off over the following 3 years. So the way that it really impacts on us locally is it impacts on the level of funding that's available to us for that following year. So it's almost a ever decreasing circles type situation, isn't it? If we overspend in 1 year, the budget available to us in the following year becomes tighter as a result. So we get growth money in each and every year, as Robert was describing. But if we are repaying a historical debt over a period of time, that growth money becomes less. So it makes it more difficult for us. As I say, though, that's what the guidance tells us, but that hasn't happened before. So the guidance often changes when the whole of the NHS has financial difficulties. They kind of think, well, there's no need to punish everybody.
Okay. Ooh, interesting stuff. Bessie, are you on the same subject of debt interest or something different? Excellent, and go for it in that case.
Thank you very much indeed. I'm really looking at page 72 to 74, which shows that only 41% of staff have relevant care qualifications. I just wondered what can be done in terms of training.
That was actually the previous paper.
Sorry.
We on to the next item. That was a slide deck that I said don't look at.
Sorry.
So we're actually on the MTFS item 10. What you've just referred to as the previous item.
On item 10, I haven't put my number in. That's
That's
leave
okay.
It then. It'll come up.
Save it up
again.
for the next
Sure,
time. In 6 months from now, we'll get that paper back and you can ask that question.
That's fine.
Okay, no problems at all. I think the next one we've got in that case is Mr. Hills. Mrs. March, Councillor March. Why? Nobody has consistent titles in this room. This is very confusing. Right. Okay, Dr. Hills.
Dr. Lee.
Perfect, I'll get it then. Thank you. My question was around the increase in national living wage and how it's going to impact on the financial strategy budget. I asked because, the County Council has been reviewing its MTFS, or I don't think you call it an MTFS, do you? What do you call it? An MTF? Something else? An MTFP? As we call it, an MTFS. And the increase in the national living wage that I understand the County Council officers weren't really expecting has added, I think, about 10-20 million to our deficit. See it where it mentions inflation here on point 12. It says no, inflation related to pay has been much higher than anticipated, but that has largely been funded. Now, obviously, if you have to pay your minimum, your staff that are on the lower wages more because of this national living wage increases, all the other staff as a knock-on effect want more as well that are on the higher bands of change. Does that national living wage increase affect the NHS much? I know there's an agenda for change pay scale. Am I barking up the wrong tree here?
Sorry, I wouldn't say necessarily barking up the wrong tree, but I think the NHS does look to fund the pay agreements that it makes with all of its relevant bodies, whether that's the consultants, doctors, nurses, and allied health professionals. So in the context of the national living wage, I don't think our lower grade agenda for change bands probably are above that. But if they're not, they should be covered by this anyway. So basically, it says in here, for example, that the pay estimate was 2.1%. That would be planning purposes. When it actually happens, what typically becomes agreed is that becomes funded separately nationally through the Department of Health. So it is hopefully covered. Now, that's not always the case, and quite often you'll find you have another element of efficiency or savings to try and make, but generally it's covered, isn't it? Yeah.
I wish DLUC funded some of our increases. Yes. That would be very nice for our officers, wouldn't it?
Yes. Okay, thank you very much. So Councillor Ross, then I've got Dr. Underwood, and then Councillor March. I'm on to you. Thank you.
Thank you, Chair. My concern is about your ability to forecast. And I put it to you, I'm a lapsed FD of many years ago. Given the productivity assumption that you have, and the manpower situation that we actually have, and the turnover and the implication that has for productivity, and the additional costs that we have, not just the direct costs, I don't think we can actually sensibly put forward a forecast of 5% for productivity that is actually credible in the near term until the manpower plan has been largely resolved. Thank you.
I'll make a start and then Robert can comment on what I say. I think that's a fair challenge, really. I think the 5%, rather than being our forecast, is our required level of efficiency. So the way in which we've modelled this, we've sort of said, let's forecast our costs realistically. Let's forecast the demand realistically. Let's forecast how much funding we're going to have. And we've done all of those things realistically. And the difference between them is essentially a 5% recurrent efficiency each year. Hence why I think there's the discussion earlier about, transformation required. I think for me, it's probably realistic to assume that we could do 2 or 3% doing the things that we've always done. And, working around the edges, medical, technological advancements in drugs and those sort of things bring about change, don't they? So we do see gradual length of stay reductions over years. The NHS does become more efficient year on year, and I think 2 to 3% is probably a reasonable target at a reasonable time. The fact is, we do face that 5% target, and there's not a lot we can do about that. We're our job is to try to come up with things to bridge that additional 2 or 3%, which is why we're talking about the requirement to transform things, the requirement to make sure that every investment we make is something that brings about improved value for money. We can just keep trying, can't we? So I don't know if you want to correct anything I've said there, because it may have been a little naive, but there might be a more political answer, but that's where we are.
Yeah. One of the biggest challenges is that triangulation between the activity, the workforce and the money, because at the end of the day, the money is an outcome of that. But what we have to do is we use, as I said, what the national guidance is, and we do our best to actually determine how we would fit within that, but recognise what the assumptions are. I think that's been one of the challenges this year. People felt that the inflation, particularly on drugs, was well understated, and that has come to fruition, and that has now partially been funded through extra allocations that have been put out. But it doesn't help, because what you would like is to have as good an idea of what you should be planning on in the first place. But don't disagree.
So really,
it's still a guide, though.
My question, it wasn't intended to be a smart aleck question. It's really, are you all in the same boat, and therefore will this have any implications in terms of the perception of Leicestershire and Rutland in the monies that come forward for the capital expenditure programme? That's at the root, the reason for that question that I asked, because it's about confidence in the ability to control and forecast costs. That's where I was coming from.
I'm assuming, Ramsey, is also in the context of what has happened in the past as far as the reputation of the trust and therefore its robustness going forward.
Yes.
And talking about UHL, I think it's done an awful lot to both get the sort of the grip and control on its financial position, but I think you also have to look at the performance to date in terms of what it has managed to achieve, over the last couple of years in really reducing the wait list as far as it has done so far, but also in terms of its ability to previously to have offloaded ambulance, for example, and actually manage that in a very difficult time within its own environment. So I think we're as a system. I think the system has all supported that with extra activity in primary care and treatment centres So I think it's working better in that sense. So I think that's a real positive. I think in terms of where do we fit nationally, we're not alone. But it's, to me, it's not about being middle of the pack and therefore you're okay. You've got to be the best you can be, and I think this system wants to be there as well. It isn't just about we're okay, we're off the radar. It actually is about doing the best for your population. I know that's certainly the drive for the Integrated Care Board, and certainly for the providers as well. We want to provide the best for the population. That's the ethos that we're working to. So I think that's really important.
Stop that, actually. Okay, thanks, Lon. Right, so Janet, you're going to go next. Then it's Councillor March. And are there any other points anyone wants to raise? In which case, you're going to have the closing comment. Okay, Janet, you first.
Thank you. What I really want to bring up is, yeah, I understand that you've got to make every pound go as far as possible, but I would suggest that should never, ever be at the cost of quality and safety and the patient experience. And I don't know whether you've tried to get through the treacle that is the NHS system right now. It's scary almost. People are telling me some horrendous stories of getting lost in the system, falling through holes, being transferred from one place to another place, etc. It's absolutely impossible. And what I don't normally quote papers, but one that I read when I was doing my PhD said that the NHS is a labyrinthine set of relationships, and by golly, it really is. And that, I think, is where productivity and efficiency is much better targeted to make those relationships much, much simpler, so that the public, the patients, can actually have a streamlined service and speak to one person and know exactly what's going to happen when, and go to the next person, rather than picking up the phone or whatever they do and they speak to a dozen people and they're all told different things. So yeah, put back finances, but think of the patient at the centre of this, because they're the people that really, really matter.
Sorry, thank you. Yeah, I think that's why it's so important on the care pathways, because, you know, we are also, as an NHS, investing an awful lot in digital technology, and that particularly relates to electronic patient records. Why? Because you want people to be able to access what the patient's been told or what they need. So I think it's really important that we get that and do try to be more joined up. But I would also agree with you that we have a lot of handovers from one organisation to another, and from a patient's perspective, you don't want to see that, and we're trying to get around not doing that through making sure we've invested right in the technology, particularly on the patient record. But I know that's going to take time. It always takes time.
Can I just come back? Yeah, just to remember that there are a lot of people out there that cannot use digital.
Thank you very much. Councillor March to finish.
Thank you, Chair, and apologies in advance, because as much as I've never been a doctor or a nurse, I've also never been an FD. But I was really struck by the kind of where the questions that Mr. Harrison was asking took me as a lay person. So you alluded to something I've not heard before, which was the retained deficit carried forward for LLR. So my question is, what is that figure cumulatively now, and since when? Because when did we in the NHS and LLR ever last make a surplus? Please, thank you.
And I don't have the answer to that. It's not in my head. I've only been here a few weeks, but I will look that one up, because it will be in their annual accounts anyway, and it's in all the provider accounts. The critical thing there also is that if you fail to break even for 3 years running, there is a referral to the Secretary of State, and that's not uncommon. I've been in a number of organisations that have had that. So there is extra scrutiny on you as well as through the auditors, but that's more of a technical issue than anything else at this stage.
So just to confirm then, the committee will get reported that retained deficit carried forward figure cumulatively, and from when that's running at a later date. Thank you, Chair. Thank you.
Yeah, I can pick it up off the internet now. It's in the public accounts.
was going to say we're going to turn off the Google function. I think in this room it's committee by Google, which is absolutely awful. We're having Chat GDP next. Right. Okay. Thank you very much for that final question. This committee has hung around the finances of the trust over many years, because I know it has had a checkered history. So we will no doubt be coming back to that on a continuing basis, because it clearly is a challenge for the trust, but also one that I know members around this room are always taken great interest in. So thank you very much for that. Look, we've got one other item still on the agenda, so thank you very much for helping us on that one. Final item this afternoon, item 11, which is the UHL Our Future Hospitals Programme update, which I know has been alluded to in a couple of the questions on previous items. So welcome to Ben Teasdale, who's the Associate Medical Director on the Reconfiguration and Digital Transformation Programme at UHL. And also welcome back to John, who's obviously the COO at UHL as well. So likewise, we'll take the paper as read. Again, unfortunately, you've picked up on an item that everyone has a lot of interest in. So I'm sure there'll be some good points that people want to actually raise. We are all incredibly eager to see progress on this item, as I know you are as well. But also, my background, I'm not a doctor, I'm not a nurse or an FD, but I am an architect, so I know buildings and I know how bloody complex they are, and also how awkward clients are. So with changing demands and needs and everything else. So I suspect this is an incredibly complex thing to try and maneuver forward. But if you want to spend the next sort of couple of minutes just outlining a few of the key points that you want us to focus on, then you'll get a load of questions.
Thank you very much, Chair. Anticipating a lot of questions, I'll try to keep this relatively brief. Just by way of background, because I knew some of the council are relatively new, and we've been at this quite a long time. Obviously, in 2019, we received confirmation of funding from central government of £450 million towards what was then building better hospitals, and that was to address the major clinical risks identified within the region, as well as responding to changes in long-term conditions and ageing population. And obviously we went via the ICB out to consultation, public consultation, successfully in 2020, and that confirmed our plans to build a new women's hospital at the Royal Infirmary, to build a dedicated children's hospital at the Royal Infirmary, to expand our intensive care facilities both at the Royal and at the Glenfield Hospital, and then to develop new facilities at the Glenfield Hospital. And I think it's really important to say, despite the time that's gone by, that we remain committed to delivering services across those three sites, with a main focus on complex and acute care at the LRI and at the Glenfield, and increasingly now high volume, low acuity services at the General. It's also worth saying that despite the amount of time that has gone by, we actually haven't been idle, and we've invested well over £117 million in the buildings and schemes since then, and those are listed for you to see. In terms of what's in flight now as live projects, you've obviously heard about, and some of the councillors have visited the East Midlands Plan Care Centre. That continues on target to open in December next year. We've recently taken on and are in the process of appointing building firms and architects for the endoscopy new build, which will sit next to the East Midlands Plan Care Centre. And that was due to open in September, October 2024. And I suppose the good news for everybody is that we've received confirmation from the new hospitals programme that we can proceed and have received funds to proceed with the enabling works at both the LRI and at the Glenfield, which is really encouraging in terms of the support for our new programme whilst we await announcement of our allocation of funds. And I think I'd leave it there already, and I'm happy to ask questions. I suppose the one that I anticipate people want to know is about hearing and balance, and I think it's important to say that we didn't consult on that, and we didn't envisage that being part of things, but it's become very clear as part of the enabling works that that building needs to go in that site at the Royal. and the enabling works will enable us to move that. We have, with the ICB, engaged the users of that service and received a number of elements of feedback, of which again listed in the paper that we can talk about. But the plans will be to put that into the East Midlands Plan Care Centre as part of that development. Thank you.
Thank you very much. Right, can I see any hands up of anyone who wants to ask any? Councillor March? Councillor March, in which case you've got the floor. And then we'll have Councillor Ramsey after you in that case. Okay.
I was really struck by this balance and hearing change and the lack of consultation about that. And I guess, is there any evidence, maybe it's a question to Dr. Underwood, no, but is there any evidence? I guess if a nurse asked me to fill in a survey in person or an NHS professional on site whilst I was waiting for some treatment or to be seen, that I might give very different responses to after. So my question was around the kind of the methodology of consultation, and you know, there must be some evidence that suggests we give nicer answers to NHS professionals in person than we do to computers. So my first question is that. My second question is, what is a satellite hearing booth? Is it a mobile home? So they're my questions on that, Chair.
Would you mind if I took one at a time, because I've got the memory of a goldfish? if that's okay. So I think it's important to be clear that the ICB decides on what level we engage patients and consult, and they were of the opinion with regards to hearing balance that we should engage in the way that we have done. It's important that the questionnaires that were handed out to patients to fill out after the event, and it was not questioning whilst on site to try and avoid some of the issues that you've mentioned. And I think it's actually quite heartening in the information that was gathered that it actually does address a broad range of subjects in terms of what we've got back. It's not just been a yes, no. And so actually it's allowed us to improve our understanding of what's actually going on and what needs to change. I think it's really important that the hearing services, you'll note, actually are a community service, and there's a wide range of community service for that. That isn't the case for the balance because of the very specialist equipment that is required. And whilst there will be a move of the balance services, I think there is a plan in here to try to make the hearing services as community-based as possible. And at the end of the day, it's sitting right bang in the middle of a £400 million building at the set, which is central to what we need to do. So I think that was, if that answers your question.
That answers the first question. And the satellite hearing booth?
So I've seen one, so it's not a mobile home or a thing. The hearing booth is a specialist piece of equipment in terms of where they conduct their service. So the satellite one is actually, it's going to be in the ENT clinic. So it's actually a dedicated room with a dedicated hearing booth. The satellite means as in it's not part of what will be at the East Midlands Plan Care Centre. So by moving it, we need to provide some hearing services at the LRI, mostly for inpatients.
Just very briefly, so it's satellite as in it's not with the core hearing service, which will be at the general. It doesn't mean it's a mobile facility or anything like that. It's just a single room in the ENT clinic.
There's always much more.
Councillor Marsh, do you want to carry on?
Yes, please. Thank you. And thank you for your answers so far. As somebody who painfully read the PCBC way back 2019, I guess at some point, given the changes that are happening the whole time, there could need to be a need to reconsult throughout, and I get that would be an absolute nightmare and not what anybody wants to do. But some of the key issues that we've spoken about throughout that time are, you know, for example, the budget at that time was £400 million. It's now 640, so the budget's gone up by quite a substantial amount, and I get why. But then this has happened. There's some changes around maternity that have crept in. I just want, and there's an increase in bed numbers required based on that 5-year-old now consultation that was done. At what point would we meet a threshold, and what would that look like in terms of triggering a reconsultation process? And then I've got a couple of questions about minimum viable products as well, please.
So the requirements to reconsult are very specific, and our intention is not to need to meet those specific requirements, because one of the important things, and at the end of the appendix you'll see the cohorts in the new hospital programme. It's very important that we remain in cohort 3, and it's very important that we remain as high up in cohort 3 as possible. One of the things that puts us at a distinct advantage from almost every other trust in cohort 3 is that we have already completed consultation. So that is very significant that we've done that. And as I understand it, the need to consultation will be if we demonstrably changed what our clinical plans were. And as I've reaffirmed, that hasn't changed.
I absolutely understand the importance of trying to make sure that you're still on stream, because the risk of being knocked out of cohort 3 by delays is obviously very real. I mean, I appreciate the issue about consultation, because it is obviously important for all of us, but again, unfortunately, there are also some organisations and people who use consultation as a way of stopping things happen rather than actually making things happen. And it's trying to get that balance to make sure that people are informed at the same time as making sure that we still actually end up getting the facilities that I think everyone desperately needs and wants.
And I think it's important to say nothing that I've said should be used to imply that we are attempting to avoid needing to reconcile. I have to be very confident telling you that we haven't, nothing, despite the things that you've mentioned that have changed, nothing in terms of what we plan to do has changed from the point of view of the consultation process.
Okay, go for it, Councillor Mark. You've got the next point.
Yes, it feels like every health meeting, whether it's joint or city, we have some changes to those plans. So it's just, what I wouldn't want, and I agree entirely, we desperately need a modernisation of our hospital estate across the system, across the footprint. But it just feels like it's incremental changes here and there rather than, it's piecemeal. So that's the basis on those first two questions. Minimum viable product. MVP used to be most valuable player, didn't it? I don't know. We changed. And it sounds to me, again, it's back to this kind of new build prefab stuff, right? And I'm very concerned on a site that has kind of buildings from the 1700s, how we've mashed that together with these kind of prehab built, want cookie cutter kind of stuff. And I know I missed that visit to the East Midlands Planned Care Centre, but it just feels like how do we do that on not just the LRI site, but across those sites? How do we mash together a modular system that's like a nationwide thing with this, those existing buildings on the site already? And then my second question is about, with a view to building hospitals for the future, it feels a bit like we aren't getting we risk I can barely read my writing. There's a gap, isn't there, between the full kind of hospital 2.0 digital enhancements and the minimum viable product version of these digital enhancements. So can we clarify what that might mean when we put those modular prefabs in place, and what capacity we have in the future in 10 years time when records absolutely will need to follow patients around beds and stuff? Yeah, that's the question. Thank you.
Okay, so the first, as I understand, the first question is about Hospital 2.0 and the second one question is about digital. So let's go with 2.0. So I think everybody shared your concerns when it was first mentioned, because hospitals are not schools and they're incredibly complex. Nonetheless, I think anybody in healthcare design would completely support the concepts of Hospital 2.0, because actually if you go up and down the country, there are people are spending large sums of public money on the basis of what they know. And if I'm an emergency medicine consultant, but recently as part of the Hospital 2.0 work, I sat in a room with a bunch of ED consultants who are actually actively building now. And one of them said, we can't possibly build a resuscitation room unless there's 3 curtains on each side. It would be totally unsafe. And I said, well, that's really interesting because I run 12 resus cubicles and they've got 3 hard walls and a glass door, and we're very safe. So you've got this, what you know, how you trained, and that can't be the right way of building stuff. So Hospital 2.0 is an attempt to standardize and deliver the best care by actually sourcing what that information, the best source of information for that. There is now then an element about actually, if you're doing that, how can you try to get more bang for your buck? So that's where you come into this modular element of it. I don't think, I'm pretty certain it's not in this to the level that you're anticipating, but it does mean, for instance, that once you've decided what a standard NHS bathroom looks like in a standard NHS single room, then why would you not build those bathrooms off-site and crane them in one at a time? Because that means you can get much more better quality control, because you can do it in sterile off-site conditions, not sterile clinically, but from a building perspective. You can get much more reproducibility, and you can then outsource to different suppliers to get the best price. So it is incredibly ambitious, and I think you are right to question the ambition there. I think the important thing as a cohort 3 hospital, it's becoming clear that we won't be subject to the full Hospital 2.0 requirements. Where that sits is up for debate and discussion, and we need to see over time.
So if it helps at all, I'm currently doing a PhD in modular construction, and I have to say, if you were given a choice between somebody building what you've just described on site versus a modular unit, 99.9% of people would grab the modular unit, because the quality and the build and the infrastructure that goes into it is significantly better than actually traditional building. It is literally the best quality you can get versus something that's pretty bog standard. If that gives you any confidence.
By lack of having a PhD, I wouldn't want mine in anything, or in, FD, or but I'm concerned because it's not a blank site. It's got stuff in it. That needs to continue
most of the facilities that are being described,
this would all be this is all in new build. You can't do this kind of stuff in refurbished elements, and I think. I'm very lucky to do the job that I do, actually, because I get to go and see things that are not clinical and are really kind of cool. So we were at Midland Met a couple of weeks ago, and we're talking with Balfour BT, and some of the things that they were able to show us around that modular element is just mind-blowing. The ability to link ducting and electrical cabling that is pre-plumbed and then literally just slots together on site, as opposed to having people up in little cubby holes and welding and this, that, and the other. And the pace at which you can do that when you do that is incredible. So that there are huge opportunities. That I think the key for us is about when they'll be realised for us to use them, and actually, are we able to fit them in? So that's that. On the digital front, I think that this is a good news story for UHL. We're pretty unique in the programme of building our own EPR with a highly agile, state-of-the-art EPR supplier, which was Nerve Centre, at the same time as designing new buildings. And that gives us a key opportunity to leverage some of the digital benefits out of the EPR design that we're doing. So there's no coincidence my other role is Associate Chief Clinical Information Officer, because the trust has recognised that the fusion of those two is fundamental to the designing of our buildings. And for those who don't know Nerve Centre, it's a mobile-based, it's on incredibly modern code, and we're in the process as an organisation of putting a new patient administration system in called the PAS. It's the first PAS that's been written in 30 years across the NHS, and the opportunities that PAS will offer us in terms of some of the things that John has talked about earlier in the day around transforming care is huge. So the challenge to us as an organisation is how can we take that and then maximise what we get out of the buildings at the same time, whilst also recognising that we need to cope with the rest of the estate as well and how we integrate those. So I think we're well in a very good place from that perspective.
Councillor Marsh, you've got one last question, haven't you? Or was that it? Your handwriting's fizzled out. Okay, we'll go for Councillor Ross in that case.
Helpfully, I actually ran 2 businesses that produced modular buildings. No, that wasn't the question. The question actually goes back to February. We've and this is about productivity improvement. And we spoke in February about the University Hospitals Leicester producing a programme, a detailed programme of works. And I believe that the committee at that time expressed the view that rather than having narrative updates, they would prefer to have updates based upon a plan. And I think taking the point that my colleague made about the somewhat moving chairs that we've actually seen since the 2019 plan, which I also had the pleasure of reading, I think it's extremely important that the next meeting that you come, Chair, I would request that a detailed plan is presented of the activities. And I also believe that that is important to provide us with confidence about the progress that has actually been made on the new modular hospital units. So specifically in terms of a level of detail. Thank you.
Sorry, I will probably. Do you want to actually ask some clarification on that?
Yeah, I'm sorry. I don't. With respect, I don't understand the question.
So the question is about reporting.
Yeah, no, I understand
and
that.
Progress.
But reporting on what?
On progress.
On what?
On the university hospitals, the new hospitals programme.
Right. Okay.
Okay. So the budget.
So
you will have a budget. You will have a budget that will be finally agreed in April. We all hope. For the programme, you're ongoing currently with the initiation works on the site. So in order for us to understand what is actually happening on that programme, in my opinion, a narrative update is insufficient, and we actually need to have a programme that is actually explained to us to explain the progress that you're actually making against a plan, because your budget is based upon a plan.
Okay, so the reason you've had a narrative update up until now is that the programme has been paused because of the work of the NHP, and you may or may not have watched avidly the Healthcare and Scrutiny Committee's inquisition of the new hospitals programme on the television. If you haven't, then I would urge you to go back and watch that. I think it's very interesting to understand the frustrations of the Health Select Committee around that. So essentially, until NHP have restarted that programme and until our scope of funding is announced, I can't give you that written down because we are in a pause phase. I think, as I've alluded to, the good news is, as things have started moving again now, that we have been given notification of that we are funding to proceed with our enabling works in advance of our budget being announced next year. Once that's in place, then the entire programme at UHL will move forward, and I would be more than happy to bury you in the yards of plans that we will have.
I suspect in that case, Ramsey, there's a paper to come back, but not quite yet.
Yes,
is probably
the answer to that question.
No, I suspected as much. But the point is that it is right that this committee can understand the progress that is actually being made, both physically,
absolutely,
and in terms of spend.
Thank you. It's a good question and a fair question. I think the way I would conceptualise this is we have done a series of works which Ben summarised up until this date, which have progressed care across LLR. We are hoping to agree a package of enabling works with the New Hospitals Programme team that we can then progress over the next year. In the meanwhile, we're trying to agree that plan, the total costing, the timeline. As soon as we have that, we will happily present it here. But if we were to present something today, it wouldn't be something that we have agreed elsewhere. Does that make sense?
Yeah.
I fully understand that, but it's the principle about how we can actually provide effective oversight. We cannot provide effective oversight on a capital programme.
We provide scrutiny, not oversight.
Oversight.
Really, to be honest.
Scrutiny.
Scrutiny. There we go.
Scrutiny.
I
Thank you, Chair, for the clarification.
I think we're saying the same thing, and I'd be more than happy over the next 10 years to keep you entirely up to date. And I'm as raring to go as you are, if that helps.
I suspect all of our hair will be grey and falling out by the time the buildings are finally opened. Look, I think it's good that we actually have a rolling update on this, because I mean the good thing is if it finally starts moving, that's when we start popping champagne corks and celebrating, because at least then it starts. From bitter experience, the long programs are extraordinarily painful, and be prepared for all sorts of things going wrong in all sorts of directions. When you finally get to the finishing line, at that point everyone forgets all the pain. It's probably like giving birth, I suspect, in the sense that you suddenly have this wonderful thing in front of you, and that's all you concentrate on from that point onwards. But getting to that stage, my God, is it awful. Anyway, that's my experience of building. So Janet, do you want to have a quick comment?
Yeah. Do quick. I would really like to know what the longevity of these modular buildings are. Are they going to be fit for the next 50 years, whatever, or are they a 10-year quick fix?
It's a minimum lifespan of 60 years, which is what traditional building is. Also a minimum.
I won't be here then, so that's okay.
No.
And the other thing is the digital programs that you're now investing in. I suspect that they won't have such longevity because we're advancing all the while with technology at a great pace. But I just really wanted to pass on to you what I'm the chair of Health Watch Rutland, and what we're actually picking up from patients. And I've passed on to Richard Mitchell and others, but nothing seems to be happening, is what patients want. They want more control of their appointments with yourself. So if an appointment is sent out to them, they have to attend on the, I don't know, if you say the 28th of December at 2 o'clock. They've either got to ring and get through a whole long rigmarole of different people being passed to different different departments, etc. What they want to be able to do is absolutely
Janet, sorry, it needs to be on this subject matter.
Well, what they want with the digital is they want to have more control of their outpatient appointments, and they want to have more control of their results, because at this moment in time, if the hospital requests, say, a blood test, the GP gets the result, but the patient is left out. So can your digital systems moving forward meet patient expectations and hopes?
Thank you. So there's 2 points within there. One is, I suggest next time we bring an update, we spend a bit more time explaining the modular side of this, because I think that understanding, we probably all have a picture over the last 30, 40 years of when we say modular, a building looks like this and it does this and it lasts 5 years and whatever. That's not what we're describing here, but we need a way to bring that to life for people. It doesn't look one way, it will look excellent, etc., etc. It's a very different world of modular, but clearly we need to bring that to life for the committee. On the second point around digital, we have an incredibly old digital system. We're hoping to roll out our new patient administration system in 2024, and that will give us the platform that allows us to build things like patient portals. Until we've got that platform, we won't be able to make that step, but it's absolutely part of our plans. Alongside that, we're working to include new things, like in January, we're rolling out increased text messaging changes to appointments and other things which will make people's lives easier. We know we aren't where we need to be from a digital perspective. There's a lot of plans around how we bring that into the 21st century.
I just come back to
Literally, Janet, we're approaching three hours, so I'm literally going to close at 3 hours on the dot.
Just to say, you already let renal patients see their blood results. Why can't the general population?
So that's off subject. So I'm going to say no to that one. You can't. It needs to be on subject. We've got to keep things on subject. So look, on that, thank you very much for all the questions. We did have Mr. Jeffrey Smith wrote in and asked about have we got enough high dependency beds? Are they adequate supply? I'm assuming the answer to that is you've put the number of bed spaces in that you believe is the adequate number.
Yeah, so I think there was a specific question around the general. So the EMPCC does, because it's low complexity, high volume, will not change those bed numbers. That's if that answers that question.
Okay, and that's to do with the capacity issue as well.
Yeah.
So you're happy with what's been put forward?
Very much so.
Okay, that's great. Look.
No, I was just suggesting if you wanted to, the Health Select Care Committee.
It's the House of Commons Health Select Committee, which will be available on parliament.uk if you have a spare 3 hours and you're desperate in need to go to sleep, but with a bit of highlights thrown in, then by all means give it a watch.
Yeah.
Somebody sent me a link to a planning committee the other day, and I thought I'm not going to watch that one.
Yeah.
So it's probably the same category, but it's important that we actually keep on having updates because I think they are really, really good. There's lots of new things happening, whether it's on modular or whether it's on terminology or piffs and puffs and down with Debbie's. All of those things are there's more information and more stuff that will come back to this committee. So thank you very much to both of you for presenting the update. I think there's a huge amount obviously about to happen, so we look forward to seeing what comes next. I know there will be a lot to talk about, so we'll have plenty of questions at that point. So thank you very much for that. Next meeting is the 27th of March. That will be at 2 o'clock in this room as well. Thank you very much to all of you. I appreciate it's been quite a long meeting. We've had a huge amount to get through, but it's been high quality. Good questions, good debate, great material. So thank you very much to our colleagues from the Health Service, and thank you very much for all the